very big hello to all my dear students. So let us start with the rapid revision round. When you say rapid revision, what is the purpose? How to go about rapid revision? Common sense, it has to be question oriented. So all the lectures that you have attended and you have listened to me, now we have to talk the crux of all those chapters, so that just before the exam, just looking through it, you are able to quickly revise the whole thing. It won't be possible, you won't enjoy this module at all, these lectures, unless and until you have attended the detailed ones. So please, first we have to go through that path only, okay? Anyways, so let's start with this. So our discussion in rapid revision, I'm again stressing out here that it is going to be, to stress this point here, not stressing out. So stress this point here that it will all be question oriented. What are the questionnaires in this chapter? What are the things we will revise? Then the next chapter and so on. Okay, so to start with, we will start with the basic. What we know is, if you talk about the basic anatomy, of course the detailed anatomy is always dealt chapter wise. You have seen in the lectures. So we already know that the eye has the three primary layers, and this is the cornea, sclera, iris, ciliary body and choroid, right? We all know this. Then this is the dotted line, this is the retina, this is your lens and suspensory ligaments. The whole eye is divided into two segments. Anterior segment is everything anterior, including the lens and anterior to the lens, and this is your posterior segment that is behind the lens. What is anterior chamber and posterior chamber? We know this. This is your anterior chamber, the space, and behind this is posterior chamber. If you look at the focusing of the light rays on the eyeball, we know how the parallel light rays are bent on the cornea and lens, and it is focused first at a point just behind the lens. What is this point known as? The point is known as nodal point of the eye. So this is the purpose of discussing this. We all have to know what is nodal point. You have written it. It is the optical center of your eye, or the first focal point of your eye, right? Where the light rays will converge. Of course, the central light will not move. It will go through and through, but the light rays converge at the nodal point. Here the image gets inverted, and it is the same inverted image which falls on the retina, and your brain makes it straight. Okay, we come to one question was about nodal point. Secondly, you have to know is that where is the bending more? It is always more on the cornea. Why it is more refraction on the cornea? We already know, either because of the more curvature, which is most important factor, is more curvature with surface, anterior surface, right? Whereas what is the second factor? Difference of refractive index between air and water. These are the two factors why the bending of light rays is more at the cornea than at the lens, right? And next we also talked about that both cornea and lens have to focus the light rays, so it's very important, should be absolutely transparent, and hence both cornea and lens are avascular. We know this? Okay, then next what we know is that if you look at the whole eye, how the aqueous is formed from the ciliary processes, and from here through the pupil comes to the anterior chamber, and this is the angle. Angle is nothing but a peripheral space between iris and cornea, right? And through the trabecular meshwork, Schelm's canal, we all know this, how it is reabsorbed back into the episcleral venous system. So mainly it is the amount of aqueous. When it is more, the pressures will be more. What are the number of ciliary process? Next question, question oriented discussion here. It is 70 to 75 ciliary processes in a single eye. What next they will ask you? They can ask you about what is the normal intraocular pressure. We all know normal intraocular pressure is 10 to 21 millimeters of mercury, isn't it? Okay, the next thing that we have to know is when the pressures are more, what happens is it damages the optic nerve, and this is what is glaucoma. So I make an optic disc here. When this optic nerve formed at the disc is exiting out through the eye, and the sclera at the disc is perforated, it has small pores, and that is what is called lamina cribosa, isn't it? We know this. You have to know this very well because this is going to be mentioned in the chapter of glaucoma again. What else we have learnt here? Of course, I hope you all very well know that it is a nerve fiber layer of the retina which is aggregating at the disc and forming the optic nerve. It is entering the orbit, which is the bony cavity in which your eye is situated. Next question is, what is the capacity of the orbit? We will answer, it is 30 cc, right? Shape of orbit, we all know it is quadrilateral or pyramidal in shape, correct? Okay, so once we know a little bit of basics here, and of course what is the axial length of eye? If they ask you, you have to remember this is around 24 millimeters is what we answer if we have to take one value, especially in a hemetropic eye. right? And then we have learnt, if you remember, depth of anterior chamber, we will just make a dot between 24, that is 2.4 to 2.5 millimeter. We also learnt that 2.5 value comes as a definition of anisometropia also. 2.5 is also the value where the infants are hypermetropic by 2.5 diopters, right? So 2.5 to 3 diopters. So this is the way we learn, so that we learn it more in an interesting way and easy way. And how do we see the axial length and anterior-posterior diameter? We all know it is through A scan. Axial length, A scan, this is another exam question, right? So we have to know, and B scan is mainly used for posterior segment. And what is the total refractive power of the eye? We will know the total refractive power of eye is 58 to 60 diopters. And if we talk about the cornea, it becomes 43 to 45 diopters. So major part is through the cornea, and lens is only 16 to 17 diopters, right? They have asked you what is the index of the cornea. Index of cornea will be, these are important questions, 1.37. For the lens, you will learn it as 1.39, right? Where is it maximum? We will answer it is center of the lens, where it is 1.4 to 1.41. Okay, we go back now chapter wise, and we'll start discussing through the clinical slides and images. Okay, so now you can give the first heading, that is your diseases of lens. What are the things we have to know? First thing, they will ask you about the structure of the lens. We all know it has got a single layer of anterior epithelial cells, right? These are the equatorial cells, these are the A cells. We have learned this. Now this is the cell which is forming, the equatorial cells are forming the lens fibers, isn't it? So these equatorial cells form the lens fibers. This is the nucleus, this is the cortex, right? So we know about the structure of the lens, and of course it is covered, you have drawn it with me also, it is covered with a capsule which is very, very elastic. So if you want to make it again, this is a single layer of anterior epithelial cells, and these are the lens fibers, and it is covered by a capsule. This is very, very elastic, right? This is the capsule, which is the thinnest part of the lens. So you will answer thinnest part is, that is capsule at the posterior pole. It is capsule at posterior pole. What next they have asked you? Next thing they have asked you is, till what time period the lens fibers are formed? So it is throughout life. This is the next question we will learn, that lens fibers are formed throughout life. Then which are the youngest fibers they have asked you? So the youngest fibers are the cortex. So youngest fibers are cortex. Cortex is the youngest, of course the nucleus, and which is the oldest, you will say? It starts with embryonic, then becomes fetal, infantile, and then adult, isn't it? So this is how we will go about it. We will learn. So these are some of the important points. Then it has also been asked, lens is derived from, make a Q, lens is derived from surface ectoderm, right? It is surface ectoderm. Okay. We will also quickly talk about physiology. Physiology, lens is mainly considered dehydrated, right? Because any hydration can cause cataract. It is avascular, we know that, right? Then next question regarding physiology, let's note down. And the question is that what is the primary metabolism of the lens? So primary metabolism of lens, you will answer is anaerobic. So this is another important point. We will remember how much 80% of the glucose is metabolized anaerobically. Lens derives its nutrition from, we will answer aqueous humor. Generally it is mainly the aqueous humor. Anything which is circulating can only provide nutrition, right? Okay, then we talk about, this was the physiology. We next talk about is cataract. We all know what is cataract, any opacity which hinders the optical homogeneity. So when there is a vision is less due to any opacity in the lens, this is what is cataract. We divide this cataract into congenital and acquired cataract. What are the different acquired cataracts? We know the classification, you have learned in the lecture also. So what are the different acquired? It could be senile, it could be metabolic, it could be, what did we learn? Then it could be complicated, toxic, traumatic, radiational, and finally we also learned about associated with systemic disease, isn't it? Like these are pre-senile cataracts. So this was the classification we had learned. So this was a quick revision. Now one by one we come to, when you talk about senile, I think you remember we talked about it can be cortical cataract, it can be nuclear cataract, or it could be capsular, subcapsulars, right? We will mainly talk about posterior subcapsular. So with this framework in the mind, now let us revise the different types of cataract. So this one is what? This is the radial spoke, senile cataract, cortical. We also call it cuneiform cataract. What is the question asked here? The question here is that this is one of the most common senile cataract. Then we talk about next, this is very important, and you know what type of cataract we are looking here is posterior subcapsular, right? This is very, very important. As you know, these cells, what do they become? What are these cells? These are what are called Weddell cells. If you remember your posterior subcapsular lectures, how there is a dysplasia of the cells, and this is how it looks like. Then we talk about that this PSC, what are the questions asked? I hope you remember this. So most common complicated cataract, answer is PSC. Next question on PSC बताओ, most common radiational cataract, again you will answer PSC. Then third question on PSC is, this is one lenticular opacity which causes maximum diminution of vision. Don't forget this. Okay? Yeah. So, and of course steroids, when you talk about toxic cataracts, I hope you remember BSC causes PSC. This is what we have learnt. So this is caused by busulfan, steroids and chloroquine. Steroids have been your exam question. So busulfan, steroids and chloroquine. That was about your posterior subcapsular cataracts. Okay, we come to the next. This is what you can see here. This is the corneal slit, and what you see here is this type is nuclear. So we just discussed one type of the senile as nuclear. When you talk about the nuclear cataract, what are the questions that come into your mind? Because it's a central opacity, right? In the center, it may lead to day blindness. This may cause diminution of vision more in the daytime, or sometimes even day blindness or diminution of vision more in the daytime. What is the next thing they have asked you about nuclear? I hope you all remember is the exam question, second sight of old age. So second sight of old age is due to, so you all remember what is this? We have discussed it is improvement of near glasses which is happening in nuclear sclerosis. So this process is called, another question, sclerosis. What is sclerosis? This was asked. So first let me discuss sclerosis here. Sclerosis is more of insoluble protein, less of soluble proteins. Hai na? Solubles are crystallines and insoluble are albuminoids. Because of accumulation of more insoluble proteins and also pigments. So increased insoluble protein and pigments. Which pigments, if they ask you? This was your exam question on melanin. So it can be melanin, it can be urochrome. So whatever may be the pigments, this pigment deposition and more insoluble protein is leading to sclerosis, which is causing hardening. This is the cause of nuclear cataract. When there is hardening, what is happening? It causes increased refractive index of the lens. And when this refractive index increases, the refractive power will be more. I need lesser power on my specs. So my improvement of my glasses, near glasses, is what is called second sight of old age. Okay? This was another important question we had discussed. Another question is, what is the most common complication of the nuclear sclerotic cataract? Most common complication we will answer is subluxation of lens. Another question, what is the most common cause of subluxation? Most common cause of subluxation overall will be trauma, right? So these are some important questions we will learn around nuclear cataract. We come to the next slide. This is of course the same, telling you the process of accommodation. You all know what is accommodation? Contraction of ciliary muscles, number one, which causes relaxation of the zonules, and when the zonules relax, there is mild increase in curvature of lens. More the curvature, more the refractive power, and this is what is accommodation, right? So if this radius of curvature, unaccommodated lens may, if you will see, this is 10, this is 6 mm, and this becomes the same 6 and 6 mm, right? Why? Because of the increased curvature of the anterior surface of the lens. This is the Helmholtz theory of accommodation. You can see how this is relaxing, and when the zonules relax, how this will be causing increased curvature is happening. Okay, so that was about accommodation. A quick recap here. And what is this? You see is at the ends, this is one type of hypermature cataract which is called Morgagnian. So this is hypermature Morgagnian cataract. We all know this. So hypermature, so any stage can be there in the cataract, and this is your hypermature Morgagnian cataract. In a cortical cataract we see as the ends. Now this you can see how by moving the head the nucleus dances. These points we have learnt earlier as well. Let's come to what question has been asked on this. The question they have asked you, we will keep two things in mind. First important thing is most common complication. Most common complication क्या बताओगे? You will say most common complication is phacolytic glaucoma. You remember this? So what was phacolytic glaucoma? That means leakage of lens protein blocking the trabecular meshwork. है ना? Why leakage of lens protein? Because of the hypermature cataract, there is wrinkling of the capsule and leakage of the... What is the second question? If you have to operate it and you are not able to see the capsule clearly, during surgery, what we can use is trypan blue as the dye to delineate the anterior capsule, right? To stain the anterior capsule. These were the two important questions asked in the exam. We come to the next one. What is this? Okay, so this is one of the pre-senile cataracts which is seen in myotonic dystrophy. You are looking at Christmas tree cataract. So Christmas tree cataract, all of you, kya padha tha? This is seen in, this was one question, myotonic dystrophy. Can we also revise the other ocular features of myotonic dystrophy? So if you think logically, it's a myopathy, there is ptosis, right? Then there is low intraocular pressure, right? Then we are already learning pre-senile before old age. So pre-senile, generally around 50 or before 50. So this is pre-senile cataract. And then what next? There will be pigmentary retinopathy. We all know this, salt and pepper fundus, right? Where the pigments are deposited or scattered here as a salt and pepper fundus. So this was about your Christmas tree cataract. A quick revision here. This is what they have asked you, right? So these are all, as you can see, needle-like opacities which are colored. Let's see the next picture. Okay, so this is your again a pre-senile, and this time this was due to diabetes. So diabetic cataract. What is this picture known as? As we know, this you can consider it pre-senile. It is mainly under metabolic cataract, right? So what is this? This is snowflake or snowstorm. Snowflake or snowstorm cataract. What are the things they will ask you under this? Snowflake and snowstorm more common in type 1, right? It is, and why do you get a cataract in a diabetic patient? We will answer this is due to sorbitol accumulation in the lens. Sorbitol is very hyperosmotic and it will imbibe water. Which enzyme is responsible? It is NADPH dependent aldose reductase. NADPH dependent aldose reductase. Right? Okay, we come to the next one. So these are the points we have to remember for diabetic cataract. And one more important thing, frequent change of glasses are not due to diabetic cataract. Which cataract causes frequent change? You will say intumescent. Okay, when the water is more, there is more swelling of the lens and therefore more curvature. More the curvature means towards more power, which is called towards myopia, myopic shift. And when it is towards less power, we call it hypermetropic shift. I hope it's clear to you. Okay, so what is very important, it is not the diabetic cataract, but diabetes itself can be cause of frequent change. How? When there is hyperglycemia, what will happen? More swelling in the lens is going to lead to myopic shift. So in hyperglycemia, there is a myopic shift, and in hypoglycemia, we see a hypermetropic shift. And hypoglycemia, it is hypermetropic shift. Clear it? So this is another important thing we all will learn. That is why if a patient is coming to me, I should be very sure that the blood sugar levels are normal before refraction, right? We come to this next slide. This is again a pre-senile cataract which is seen in, answer me, this is your atopic dermatitis, which is another cause of pre-senile cataract. Okay, so this is what is called shield cataract. So this is what is shield cataract. Okay, we come to the next one. Another metabolic cataract. You all know this is what is oil droplet cataract. Oil droplet cataract is seen in galactosemia. Right. Which enzyme deficiency? Deficiency of GPUT, galactose phosphoruridyl transferase. Correct? Okay. Then they have asked you, is another important question. They have asked you about reversible. So you will answer, this is mainly, if there is any cataract which is reversible, it is galactosemia. Okay? Okay, we come to the next. This is another metabolic which is called calcosis. We all know that copper in the eye is calcosis. So when you say chalcosis, some people pronounce it that. It's okay to pronounce whatever. I call it calcosis. So when you say calcosis, what do you see here? We see golden brown copper deposition. This is your KF ring. Okay, very important topic these days. A lot of questions here. KF ring, quick revision all of you, is mainly copper deposition in Descemet's membrane. We all know that. It will start from superior to inferior and then it will later become a circle. So it starts superiorly and inferiorly. You know, arcus senilis also starts like this only, superiorly and inferiorly. Then we come to the third point. All patients of neurological complications of Wilson's disease will have KF ring, but hepatic involvement patients, not all but only, you will say 65 to 67% patients have KF ring. This was your answer of your question, which was a wrong statement, where it was written that all patients of hepatic involvement have KF ring, which is wrong. Only these percentage of patients can have KF ring. I am talking about Wilson's disease, right? This is in Wilson's disease. So these are the questions on KF ring. Then of course we know this is your sunflower cataract, which is itself an exam question. So sunflower cataract. Okay? Okay, we come to the next one. So what is this next one? This is again you're looking at sunflower cataract, which was not clear earlier, and this is mainly a feature of calcosis. This is enough. We next talk about another metabolic is Loeys syndrome. Loeys syndrome, apart from cataract, is characterized by posterior lenticonus. Okay, so this posterior lenticonus, the question they have asked you, posterior lenticonus is a feature of Loeys syndrome, which is also called oculocerebrorenal syndrome. It is also called oculocerebrorenal syndrome. Right? Then next question is on anterior lenticonus. As you can see, this is the anterior lenticonus, isn't it? Anteriorly it is seen. This is the corneal section, so this is anterior. So anterior lenticonus, what are the questions asked? Anterior lenticonus is seen in, we will learn two syndromes. One is Alport's. You all know Alport's is hemorrhagic, familial hemorrhagic nephritis, and second is your Waardenburg syndrome. Padha tha na? Okay. Then what is the next thing that they will ask you? Next question is, it is more common in males, right? Okay. So these are the questions on anterior lenticonus. Another reflex on anterior lenticonus, let's not forget, oil globule reflex. It is seen on slit lamp finding on retroillumination. Okay, I have explained you what is retroillumination. So these are the points we will remember for anterior lenticonus. Okay, we next talk about, this is the next slide. What is this? As you can see, again it is overlapping with some picture like Christmas tree, but of course the background history will help you to diagnose. So this is mainly, it's already written for you, polychromatic luster breadcrumb appearance. This was this recent exam question. So let's hear it properly. This is complicated cataract. We all know complicated means any cataract which can be either due to anterior segment disease or posterior segment disease when it is occurring as a complication. What are the questions? First question is, most commonly it is posterior subcapsular. Second question is pathognomic feature. Please answer pathognomic feature as polychromatic luster. And of course the appearance is breadcrumb appearance. These 3 points you should be remembering for complicated cataract. Let's see the next one. Okay, so what is this? This is actually rosette shaped cataract. We learn it in, so we are now talking about traumatic cataract, that is rosette shape, which is your blood due to blunt trauma. So this is itself exam question, that this is a feature of blunt trauma, right? Then what next they have asked you? That from where does it start? It starts from posterior cortex, So please don't be misled that okay, this is single line question or what, or is it a whole paragraph question. Concept doesn't mean that it cannot be a single line question. Anything, all these Qs and double Qs are very important. It can just be a part of your options. You never know, right? So let's focus. Then we talk about next important thing is this one. Again, if there is a blunt trauma, what are you looking out here is disinsertion of iris. What do you call this? Iridodialysis. Iridodialysis, what type of shape of pupil is your exam question? As you can see, this is D-shaped pupil. Okay, so this is your important question. This is a D-shaped pupil of iridodialysis. Again, a feature of blunt trauma, right? So we come to the next feature of the blunt trauma. As you can see, what is this? This is your imprint of iris pigments on the where? Anterior capsule of the lens. So this is what is Vossius ring. Number one, important question that this is a feature of blunt trauma. They ask you where is it situated. We have made this diagram also, if you remember. It is on the anterior capsule of lens. Okay. Yeah. So that was about the Vossius ring, another feature of blunt trauma. Okay, then what are you looking here now? Dhyan se dekho, this is what blue dots, right? So this is a blue dot cataract. So we are talking about blue dot cataract. What are the two important questions that we'll keep in mind? First, I have told you blue dot cataract is most common congenital cataract. This is one exam question. And second exam question will be that blue dot cataract can be a feature of Down syndrome. I don't think they had asked you once this information was used as an option, I remember. Okay, so just remember these. That was blue dot. Coming to this one, what is this? This is your lamellar cataract. So when you say lamellar cataract, very important, lot of questions again. So this is your when you say lamellar cataracts in a congenital cataract, we have to know that we are talking about first question, most common congenital cataract causing marked diminution of vision, where the visual acuity is markedly reduced. Second important question is, it can be associated with which vitamin deficiency? Vitamin D deficiency. Third question they have asked you about, riders are a feature of, we answer lamellar cataract. What are riders? They are additional opacities like this that you see here. These are riders. It's a feature of lamellar. What is another cause of lamellar? I think I have discussed this in snapshot also. And what is another cause of lamina? We will answer. It is your rubella. Okay. So rubella infection. What is this? Next type of congenital. So now we are discussing all these congenital. First was most common blue dot, then lamellar. Now this is your posterior polar, and I hope you can appreciate the onion peel appearance. Right. So this is a posterior polar cataract with onion peel appearance. So what are the points we will remember for posterior polar cataract? First is your onion peel appearance is done. Second important thing that you have to understand here is that it is very tricky cataract surgery, right? Why? Because of the high risk of posterior capsular tear. There is high risk of posterior PC tear. Okay. What is the next type of congenital? Of course, we cannot forget the important topic, congenital rubella syndrome. So when you say congenital rubella syndrome, what are the features? What type of cataract? So do you all remember the triad we had discussed with the mnemonic CHD? Stand for cataract, heart defects and deafness, right? Cataract, heart defects, deafness. Okay, so once we know about cataract, heart defects, deafness, what is the next important thing is what type of cataract is most common. So most common type of cataract, most common we will answer nuclear pearly cataract, right? Most common type of cataract. But if they ask you most common ocular feature, do we remember this? Most common ocular feature is salt and pepper fundus, pigmentary retinopathy, salt and pepper fundus, right? Okay, so what are the ocular features? Yeah, so this is what is salt and pepper fundus as you see in this patient. Okay, where the pigments are all scattered in a salt and pepper form. So ocular features of rubella we can just revise with the diagram here. So if you start thinking from outside to in, this is how we learn the ocular features in my style. So what happens in the eyeball? We all remember this. There is microphthalmos. Microphthalmos, how do you describe? What did we learn? Any axial length of less than 21 millimeters, or at the age of 1 year if the axial length is less than 19 millimeter. Both the criteria are definitions of microphthalmos, right? Then we talk about next important feature is rubella keratitis. That is number 1 is microphthalmos, second rubella keratitis. There can be angle anomaly leading to impaired drainage and glaucoma. Then there can be rubella. This is your nuclear pearly cataract. Starts with nuclear pearly cataract, and of course we will make this retina and right here salt and pepper fundus. And what did we learn? Most common feature is salt and pepper fundus. This becomes the most common. Okay, so most common we will learn salt and pepper fundus. That was about your rubella. Okay, so once we know the different types of cataract, we talked about acquired cataract, we talked about different congenital cataract, how it presents, blurring of vision, diminution of vision, right? We have to remember all those points that we learned, what is second side of old age, right? And what are the different complications of Morgagnian and that of the nucleus sclerotic. That is done, right? Okay, then we talk about when you say treatment, we all know there is no medical treatment and the only treatment is surgery. When we talk about surgery, what are the different surgeries? First is your ICC. Let's revise what was ICC, where you are removing the whole lens along with the whole capsule. Right? So when we are removing, what are the questions asked? Again, discussion is question oriented. So what are the questions on ICC that you should know? First question they have asked you is, what is the best method? Best method we all know is cryo. It is cryo extraction. Right? Then the second thing they ask you is, what is the only indication? We don't do this because we need the capsule to put the lens. So what is the only indication? Only indication we are going to answer here is, the only indication of ICC, everyone, is subluxation of lens. Especially when you are talking about more than 9 clock hours of subluxation. Right? Then we have to go for ICC. Otherwise you can put capsular rings to support the capsule. And then what is the third thing we have to keep in mind? This surgery is contraindicated in children. It is contraindicated in children. Okay, so why is it contraindicated in children? I hope you all remember, it is due to the adhesion with the anterior hyaloid membrane, which is called Wegert's ligament. So due to this Wegert's ligament, which is going to pull on the membrane, pull of the vitreous, can be a risk of retinal detachment. And this is the reason it is contraindicated, right? Okay. So that was about ICC. Next surgery is ECC with PCIOL. We all know how we keep the posterior capsule and put the intraocular lens in it. So this is the section which is being made for extracapsular cataract extraction. Okay. What are the points we have to keep in mind when you talk about the lens? This is the optic and this is the haptic. Haptic is the supporting part. We all know this. Correct? So what are these IOLs made up of? There are different IOLs we have discussed in the lecture. So if they say IOLs, we just mean non-foldable, then our answer will be PMMA, polymethyl methacrylate. Polymethyl methacrylate. And if we are talking about foldable IOLs, we will not forget foldable IOLs are generally made up of silicon, acrylic and hydrogel. Right? So generally it is silicon, acrylic, which are most commonly it is the acrylic. Hydrogel. Most commonly it is mainly the acrylic. Okay, when we are talking about this, which is the lens which will lead to least chance of posterior capsular ossification, it is hydrophobic acrylic. Hydrophobic acrylic will have least chance of PC capsule opacification, least chance of posterior capsular opacification. Right? Okay, so anything else they have asked you for ECC? You should be knowing very clear what is hydrodissection, what is hydrodelineation. I hope you know this at this point. Okay, we come to the next one, and what is the next question asked? So this is, as you know, we are making a scleral tunnel and I am talking about small incision cataract surgery. So it can be either done manually. If it is done manually, this is how we make the tunnel. So this is actually, you are looking at a manual small incision cataract surgery, right? Yes. So it's a self-sealing incision. Generally, we don't require sutures. You should keep this in mind. They have not asked you, but what is generally the incision length? Around 5.5 to 6 or 5 to 5.5 is the best data to learn, is 5 to 5.5 millimeters. We come to this. So this you should know what was ICC, ECC. Then I am revising with you small incision. Small incision we are saying can be either manual or phaco. Now one more thing, what is the benefit of small incision? Let's revise that also here. So small incision cataract surgery, first of all, incision is small and there are no sutures. Because there are no sutures and there is a small incision, what happens is least post-op or almost negligible or almost not at all, okay, negligible post-operative astigmatism. This should be very clear why we are doing so much of hard work and doing the surgery in small and smaller incision. So that is happening because that will not lead to any post-operative astigmatism. Now I think we can move further. So here we are looking at, as you can see, this is the irrigation aspiration going on in this one. This is a phacoemulsification. You have already seen the surgery of phacoemulsification. What are the questions on phacoemulsification they have asked you? So I think we can revise this quickly. First is, what is the incision length? So this is 2.75 mm to 3.2 mm. I think I have taught you this as पौने 3 से सवा 3. You remember this? Then second important thing is they have asked you what is the frequency of phaco probe. Frequency of phaco probe we will answer is around 40 kilohertz. right? And then they have asked you what are the IOLs we put. We will not be able to put a non-foldable, so we generally go for the foldable intraocular lens. These things in mind. And which is the latest in cataract surgery? This one has been your exam question. The whole slide is your exam question. This is what you're looking at is femtolaser cataract surgery. So when you say femtolaser cataract surgery, you have to know what are the three things we do with femtolaser. We can make the incision, right? We can then do the second is this one capsulotomy, and third is this one lens fragmentation. So 1, 2 and 3. These are the three things we can do with femtolaser. And what is the pulse duration? 10 to the power minus 15 seconds is the pulse duration. We will remember this, okay, for femtolaser, right? So it is generally in infrared range, and what is the main wavelength is 1054 nanometers, right? Okay, so that was the cataract surgery. Once you have operated, you want to put the IOL, right? What is the SRK formula? You should remember it is power is equal to A minus 2.5 L minus 0.9 K. So L is the axial length, K is the keratometric reading, and A is the constant. This basic SRK you should know, but what? So this is also called SRK1. Now we have a modulation for very short eyes and long eyes. So we will remember this. Shorter eyes, we generally go for Hoffer's or Hoffer Q. Longer eyes, SRK by T. And if you have been gone under LASIK, now any measurements of the IOL power cannot be based on your corneal parameters. So this is a different method of calculating, which is called Haig's formula. This was your exam question. So post LASIK, which formula we use? Haig's formula. Then you should also know about SRK, right? Yeah, and then one more important thing to be revised here is what is the ideal time of operating a child of congenital cataracts. So what we have learned is ideal is after 1 month. Before 1 month there will be a lot of inflammations and trabeculitis which can lead to glaucoma. But after 1 month we don't want to wait further. We want to almost it is like immediately only, isn't it? After 1 month is almost like immediately you are putting the. Why we are doing it? Why it is as soon as feasible we have to implant the lens? To avoid any amblyopia forming. Why amblyopia? I think you remember this diagram which I taught you, that how the light rays are falling on the retina and then that stimulates the fovea. And this is taking place with fovea maturation or foveal reflex formation by 5 to 6 months of age. Right? So if this child has got cataract, no light is falling, fovea will not be formed and vision cannot be 6 by 6, the patient becomes amblyopic. So remember this, it is important. So to avoid amblyopia, we are operating almost as soon as feasible. If this option is immediately or as soon as feasible, we will mark that. But if among the 4 options there is written after 1 month, I am going to choose that option after 1 month. Okay? Yeah. So this is I am telling you according to this latest 9th edition of Lansky. So no confusions here. Okay. After this, what next we have to revise is, of course, what is the complication after cataract surgery? 2 things we have to know. Most dangerous complication kya hai? Endophthalmitis. Okay. So most dangerous complication we will learn as endophthalmitis is the most dangerous. This is something dreaded complication we never wanted in our patient. Now, why? Because it is so difficult to save the eye after that. So, most dangerous, first question. Second question they have asked you is, what is the treatment of choice of endophthalmitis? I think you all know it is intravitreal antibiotic injections, isn't it? Now, intravitreal we can give ceftazidime, we can give vancomycin, and if it is fungal, what do you give is also asked in the exam. Amphotericin B can be allowed, voriconazoles can be allowed. Okay, so for antifungus, intravitreally allowed are amphotericin B or voriconazole. But this has to be only when the vision is still better than at least hand movement. Any vision less than hand movement or only hand movement, then we have to go for hand movement and only hand movement less than that or equal to hand movement. Now we will have to go for pars plana vitrectomy. In that case, I am going to do pars plana vitrectomy. Is there any other question we have to know? Yes. What is the cause of immediate acute onset endophthalmitis and cause of late onset? So I hope you remember. I am not writing but I am speaking here. Acute onset you are going to answer is staph epidermidis, and late onset you are going to mention is propionibacterium acne. If propionibacterium is not the option, the next best option will be fungal. This is all they ask you about endophthalmitis. And of course you know the features. You can see the hypopion here. Right, we can see all this corneal haze, corneal edema, there will be uveitis, no fundal glow, which is very, very important, and therefore the vision is dropped down, there is pain, congestion. So this is your endophthalmitis. What is endophthalmitis defined as? Generally inflammation of the inner coats, right? That is vitreous. Mainly the vitreous is prominently involved along with the retina. Okay, so that was endophthalmitis. Now we come to what are you looking at? This is a very, very important question. This is the most common late onset complication or late onset complication. Long term, or you can say they can ask you long term complication, most common batao. So long term complication is this one. What are you looking at? This is posterior capsular pacification. What are these? These are Elschnig pearls. I hope you remember, apart from Elschnig pearls, it can be Sommering ring or it could be just a diffuse opacity. Next question. I have already discussed which IOL there is minimum PCO. We will answer hydrophobic acrylic. Third question. Treatment of choice. What is our PCO also called? After cataract. We are actually talking about after cataract. So third question is, what is the treatment of choice of after cataract? We are going to answer, it is Nd:YAG laser posterior capsulotomy. Nd:YAG causes what? It causes hole formation. So Nd:YAG laser posterior capsulotomy. So Nd:YAG laser posterior capsulotomy. Okay? Then now a connected question, though not in after cataract, but what is the wavelength of Nd:YAG? It is 1064 nanometers. What is another indication of Nd:YAG? Let's not forget peripheral iridotomy. Na? Peripheral iridotomy किस lens से करते हैं? All of you, we remember Abraham lens. We have learnt Abraham lens. Okay, so much information on this slide. We can move to the next one. What are you looking at this now? This is your subluxation of lens. In this case, it is inferior subluxation, and we can even see the golden crescent, which is so typical for diagnosis of subluxation of lens. Okay, subluxation of lens, most common we have already told you is due to trauma. What can be the other causes? Of course, other causes can be Marfan's, homocystinuria, Weil-Marchesani, Ehlers-Danlos loss. And do you remember also causes I discussed? Hyperlysinemias, sulfite oxidase deficiency. So all these causes are causes of subluxation. Now question oriented. Let's go back to the question. First thing is, they have asked you which direction Marfan's, which direction homocystinuria, and Weil-Marchesani. They have asked you in all three. Let's remember, Marfan's, it is in my style, we are going to year-long style here. Huh? So this one, make an M and put an arrow on the head. So for Marfan's, it is always supero-temporal ectopia lentis. Right? And now we make a dotted line just opposite to this and make an arrow, write here H. So in homocystinuria, it is just the opposite, infero-nasal. So in homocystinuria, it is infero-nasal. Right? Then of course, Weil-Marchesani or Marchesani, both the words are correct and terms are correct. Marchesani or Marchesi. So what is you see here is downwards and forward subluxation. Downwards and forward subluxation. Right? So these are the important points we have to remember about subluxation of lens. Okay, so that was about diseases of lens. We are now heading towards the second chapter, and that is glaucoma. Let's talk about glaucoma. We all know glaucoma is damage of the optic nerve in some particular pattern which we have to study, right? And it is majority of the time the major risk factor is your increase in intraocular pressure. So starting with this first slide is about, we will revise the formation of aqueous humor. As you all know, aqueous humor is mainly formed from these non-pigmented ciliary epithelium. Right? So if we make it our simple way, it becomes life is easier. So if this is a ciliary process and these are the blood vessels, this is the stroma, and then we are learning that there are two layers of epithelium. One is inside with your pigmented epithelium, one which is outside is non-pigmented epithelium, right? This is the non-pigmented epithelium, and it is this non-pigmented epithelium from where majority of the aqueous is formed. This is your exam question, right? And mainly through the sodium-potassium ATPase pump. I am not writing everything, but we are revising quickly here. So through sodium-potassium ATPase pump, and this process which is energy dependent is called secretion. And what are the other processes contributing? Ultrafiltration and diffusion. So ultrafiltration and diffusion are also contributing for the formation of aqueous humor. Okay? That is one question. Second question they will ask you, what is hypersecretory glaucoma? So we all know that normally the glaucoma is happening due to more amount of aqueous, and this more amount of aqueous is due to impaired drainage. When it is due to more formation, we call it hypersecretory glaucoma. Where do you get it as exam question? We will answer epidemic dropsy. You can revise this through in your PSM, epidemic dropsy. Another important fact we will revise here, that what is the rate of formation of aqueous humor. Rate of formation of aqueous humor we are going to learn is at 2.3 microliters per minute, right? Then we talk about is the outflow of the aqueous. As you can see here, one outflow which we have been making since the first slide is your conventional outflow. How the aqueous from the posterior chamber, then through the pupil, coming to anterior chamber, then going into the angle. And what the angle has got are the trabecular meshwork, and this flow is what is called trabecular flow through the trabecular meshwork and Schelm's canal. Whereas some of the aqueous from here directly crosses the uveal tissue and goes into the scleral part, that is episcleral venous system, and this is called uveoscleral outflow. So we learned two major types of outflow, a quick revision of the outflow here. One is uveoscleral and one is your major part is 90% is conventional and 10% is uveoscleral. This is 90% is conventional and 10% is uveoscleral. Okay, this is about your aqueous outflow. Then we have to be very clear what are the two terms mean when we talk about is what is open angle glaucoma and what is angle closure glaucoma. Now before that, this is the slide so that your concepts are very clear. Where is the Schelm's canal? So trabecular meshwork, then this one is your Schelm's canal, right? And this is the episcleral venous system. I think this one is very simple to make you understand what is the conventional flow. Okay, so this is what is the conventional outflow. Chalo, then we talk about, we were saying what is the open angle and what is angle closure. Do we realize what is open angle? When there is blockage in the trabecular meshwork. And what is angle closure? This is seen so nicely here. Any cause of the pupil block so that there is a push which is actually abutting the space between iris and cornea. What is angle? It is the space between iris and cornea. When that angle is obliterated, we are calling it angle closure, right? So we will learn like this, that open angle means, so if these are nothing but impaired drainage ke do types hain. These are the types of impaired drainage. One was, when we make a diagram in our way, please. This is simple. So we are saying here that one is your conventional outflow, right? So any problem when it comes in the trabecular meshwork and there is a blockage out here, now the impaired drainage, this is called open angle glaucoma, right? This was the drainage. But if there is no problem here, but problem lies in the fact that due to some cause of the pupillary block, what is happening is iris is moving forward, and this moving forward iris is abutting in the cornea. There is no angle space. This is what is called angle closure glaucoma, right? So impaired drainage can be due to angle closure or it could be open angle. Be very clear about it. Okay. Once we know this much of basics about formation, about the outflow, about what is angle closure, what is open angle, you should be able to define what is glaucoma. We generally know it, we don't have to mug it up, but be very clear, it is a group of, it is just a multifactorial optic neuropathy, right? So a chronic progressive optic neuropathy which results in characteristic morphological change. So I am generally putting this as definition here because exact words here from the latest version, okay. So this is your characteristic morphological, and we are saying that IOP is a key modifiable factor. Why we are only calling it a key modifiable? Because there are cases where the intraocular pressure is normal, still there is damage of the nerve. This is what is called normal tension glaucoma. Done? Okay. So that is the reason we have to know. So I hope you are very clear about this. Okay, so once we know what is glaucoma, we come to how to classify glaucoma. So glaucoma can be classified as classification, we all know this, it can be congenital or acquired, right? So when you say congenital, quick revision, it can either be true congenital, that means the child is born with the problem, then it is true congenital. It can be infantile, infantile is within less than 3 years of age, and anything from 3 years to adolescence is juvenile, right? We know this is what is juvenile. So it can be infantile, it can be true congenital, it can be infantile, it can be juvenile. And we all know that till 3 years of age, the sclera is very soft. So any rise in the pressure in the eyeball is causing stretching of the sclera, enlargement of the eyeball, and this is what is called ophthalmos. So ophthalmos will be feature of true congenital as well as infantile, but it cannot be for juvenile, because it is only up to 3 years that the sclera is stretching. And of course, when you talk about acquired, we will talk about acquired glaucomas can be, again, we can learn like this: primary, secondary, a simple way, and primary can again be open angle or angle closure. Similarly, okay, secondaries can also be learnt as angle closure or open angle. So either type may be, right? Okay, so once we have this basic idea, we one by one question oriented discussion here. So we next talk about is what are you looking here. So if I talk about the acquired glaucoma first, I'll take primary open angle glaucoma. When you talk about primary open angle glaucoma, we all know when it is open angle, what is the main pathogenesis? That blockage is in the trabecular meshwork, right? This we know. And which are the major risk factors? It is important for your exam, so I am discussing the risk factors. The risk factors for glaucoma would be, first of all, very important is increased intraocular pressure. Second would be your any age of more than 40 years, then positive family history and high myopia. These four are very important that you have to know as the risk factors for primary. Means we do not know the exact cause. So these are the risk factors why this patient can develop damage of the optic nerve, right? And then of course the three cardinal features, if I talk about the clinical features here for open angle, we all know it can be either three major things we have to discuss is IOP changes, intraocular pressure changes, then because of that if there is a damage there will be fundus changes, and later there is going to be visual field defects. Okay, so one by one we are first talking about is IOP changes. So majority of the times IOP is more, right? And what are you looking here? We are looking at Schiot's tonometer. Schiot's tonometer is nothing but it's an indentation tonometer where you are indenting the cornea. We all know this, right? Okay, so Schiot's tonometer is an indentation type of indentation tonometry. Now, IOP changes, what are the points? We will quickly revise here. Asked in the exam, one is your normal intraocular pressure. We have just learned it is 10 to 21 millimeters of mercury. And what is the next important thing that they can ask you after this is what is the normal diurnal variation? So up to 5 mm of Hg is normal diurnal variation. And you should be knowing that there is a diurnal variation when it is more, when it is less. M for M, it is more in the mornings. Why it is more in the morning? Why is the IOP recorded more in the morning? We know it is due to the more steroid levels in the morning hours. Okay, so once we know this, that this is the normal diurnal variation is around 5 millimeters of mercury. Then we have to also understand what is normal tension glaucoma and what is ocular hypertension. A very quick review here. When you say normal tension glaucoma, we mean that the IOP is normal. It is within the range. It is within 10 to 21. But I am getting the fundus changes because there is a damage of the nerve. And I am getting the field effects. Visual field effects are present, positive. And why it is happening? What is the theory? I hope you remember we have discussed this. It is all based on the vascular theory that there is some impaired blood supply to the nerve. Then what is ocular hypertension? Name suggests this time the pressures are more, but everything is normal. Fundus is normal and no visual field effects, right? Fundus normal and no visual field effects. This is what is your ocular hypertension, right? Then we are talking about tonometry, where we are learning what are the different methods of measuring the intraocular pressure. A lot of questions here, so now we will focus. Coming to Schiot's, one question is Schiot's more reliable or the other one? Which is the other one? This one. What is this you are looking at? This is also your exam slide. This is what is Goldman perimetry, right? So, Goldman perimetry, as you all know, is a type of, you will answer, applanation tonometer. What is applanation? Just touching and flattening is called applanation. And it is based on Imbert-Fick law. They have asked you once, so you should know the name of the law. And what does this tell you? That any pressure is equal to force applied upon area. Okay? So, the area here in this Goldman is fixed, and what is that area? The diameter of 3.06 millimeter. Okay? With this area of diameter of 3.06 millimeter is applanated, and we are measuring the pressure. What is the amount of force applied will be proportional to the intraocular pressures, right? Once we know this, which is more reliable? This is the next question. Which is more reliable? You will answer applanation. Why is indentation not reliable? Because reading of Chiod's depends on scleral rigidity of the patient. You know this, I have explained you in the lectures. When the sclera is very soft, it is going to indent more. If it is rigid, it will indent less, right? Okay, the next question they have asked you here is that Goldman का भी जो reading है, this is depending on, we will not forget this information, central corneal thickness. So in a thick cornea, we generally overestimate the IOP, you should know this, and a thin cornea, we underestimate the IOP, right? These things have to be revised. Which is the gold standard? Even today it is Goldman. That's why when we are doing this Goldman tonometry, we are also measuring the central corneal thickness through pachymetry, right? It's a part of our glaucoma workup. So we are still on the IOP changes. We come to the next type. What is this? This is what is applanation type. This is tonopen. What are the questions on tonopen? First question is, will now become the choice for children. Choice of tonometer for children. Earlier what you used to answer, do you remember? Perkins. But now Perkins is just a handheld version of Goldman. But now we will answer tonopen. What is the second? Second question is, this can be used in scarred and irregular cornea. Okay? Scarred and irregular cornea. So this is very important to remember. Okay? So this was tonopen. This is again an applanation. Again the same, just like applanation is of two types. If you remember, I taught you variable force and fixed force. So we are talking all about variable force because amount of force that I am applying is variable and depends on the intraocular pressure. So all these are variable forces like Goldman, tonopen. Okay. This one is another very important. This is your non-contact applanation. This is exam question, non-contact applanation. So what are you looking out here is, this is pulsar tonometer. Apart from the pulsar tonometer, if they ask you the other name for non-contact, we answer air puff. So this is exam question that this is a non-contact applanation. This is another applanation, variable force. This time we call this what is called a rebound tonometer. What is the question here? Which tonometer can be used by you yourself to measure your own intraocular pressure? Okay? So self measurement we will answer, it is your self measurement we are answering, this is rebound tonometer. Rebound tonometer. Right, all of you? We come to the next one. Yes, what is in this chart? This is the latest contact type of applanation. Exactly the principle on which it is based is dynamic contour tonometry. We will not say exactly, it is dynamic contour tonometer. What is that? It takes the shape of the cornea, right? This is called Pascal's tonometer. And what is the benefit? The reading does not depend on central corneal thickness. That means this one is even more reliable than your Goldman, more reliable than Goldman. Just remember these important points, right? And which one is the recent but non-contact type, which is again through the puff of air? Ocular response analyzer. So this is again the recent one. It is non-contact applanation tonometer, just like pulsar and air puff. This non-contact applanation tonometer is based on the principle of corneal hysteresis, right? So when the cornea is indenting in and when it is coming out, both the pressures are being measured and the difference is being seen. Okay, so just if you want to, you can just go through the lectures if you want to know more details, but they have not asked you much here, right? Yeah, so that is what is corneal hysteresis. Just imagine there are two measurements, one when the cornea is going in and then when it is coming, it is taking its position back. Both types of applanation are being recorded. Anyway, this was about your ocular response analyzer. Now then, these are the important points regarding IOP changes that you have to know. After the IOP changes comes fundus changes. Let us see what the fundus change. I hope you all remember this, what is cupping of disc. So this is a normal optic nerve. A normal optic nerve head, this is the small area, the arrow is showing you here. This is what is the cup area, small pale area of around, if you look at the whole disc, their disc CD ratio, cup disc ratio is around 0.3 or less. Then you can appreciate the rest of the area. This is what is called the rest of the area outside the cup area. This one, this one, this one, this one. This is what is called neuroretinal rim. Correct? Now look at the glaucomatous picture. So can you see the cup area has increased a lot? Okay? So a very quick revision here. What did I explain you? What is a cup? So if this is the optic disc, if you remember we talked about. So the central pale area, this is your cup area, right? So this cup area is one and this rest is neuroretinal rim. All the nerve fibers are actually occupying the neuroretinal rim. All the nerve fibers occupy the neuroretinal rim, which means cup is a non-neuronal area. Okay. So why is cupping happening? When the area of cup is increasing, usko hum kya bol rahe hain? Cupping. Actually, it is also due to modulation, remodeling of the lamina cribosa. Damage ho raha hai optic nerve mein, right? Then there are proliferation of the glial cells which are supporting cells. All this causes changing of shape of lamina cribosa and this is the cause of cupping of the disc. Okay? Revise? Okay. And we also should know why the cup is always vertically oval, which is important in glaucoma. Why it is so? Because as you know this, remember this diagram, how the nerve fibers are reaching the optic nerve head. From the nasal, it is travelling straight from here and here, right? And from the macular area again, it is travelling straight as papillomacular bundle. But when we talk about the temporal part, it curves around and enters the disc. These are arcuate fibers and the first damage in glaucoma occurs in arcuate fibers and this is the reason that the cupping is always vertically oval first. These are so important concepts that we needed to mention this in your rapid revision. I think it's absolutely clear to you all that you can get a round cup, but this is generally seen in physiological cupping. What is that? When the CD ratio is more, but there is no glaucoma. What is the main point? How to differentiate? In physiological cupping, it is bilaterally symmetrical. Correct? Okay, so that was about the fundus changes. What are the other changes you see? We will just see here. What we see is a visible opening of lamina cribosa and these greyish dots is what are called laminar dot sign. Okay? Laminar dot sign. What are the other findings? I can see some nasal shifting of vessels. Again, the nasal shifting of vessels are due to the, as I told you, changing the shape of the lamina cribosa, right? And of course, bending of the vessels once it is coming out the cup, then when it is coming out of the disc. What is this called? This is called bionetting sign. Double bending of vessel is bionetting sign, right? Okay. Then what do you see here? Again, we see the same nasal shifting of vessels. This is the cup area. Cupping, I can see the cupping of around 0.7 or maybe I can say 0.8. It is correct. Then this is what I see is nasal shifting of vessels. And what I see here is you're again bending one at the cup, one outside the disc, double bending. Okay? Okay. And why are you getting this nasal shifting is very nicely explained. If this is a normal central retinal vessel in lamina cribosa, so this is a normal situation. But what happens when there is a cupping like this in the lamina? The shape is like this now. So look at this, what is happening to the central retinal vessel? It is shifted on one side. This is what is nasal shifting of vessels. Okay, very beautifully explained through this diagram. Okay, so once I've understood this, what are we looking out here are the retinal nerve fiber defects. So this is the retinal nerve fiber layer defects, which we see here also. Sorry, and we see here also, right? Yeah. So this is again a part. Then we talk about the third important point is your visual field defect. Now visual field defects, what are the things we will learn? First important thing that we should know for visual field is what is the normal extent of your visual field is your first question. Normal extent we should know that temporally it is around 100 degrees, then inferiorly around you can say 70, then nasally 60 and superiorly 50. There can be some variation here and there, but this is correct, you can learn this. Then the next question they have asked you is where is the blind spot situated? So where is the blind spot situated all of you? The blind spot is situated on the between 10 to 20 degree isopter. It is between 10 to 20 degree isopter. Once we are clear with this, now we talk about what are the field effects in glaucoma, visual field effects in primary open angle glaucoma. Before I come to that slide, we will write it ourselves. So visual field defect, we'll start with early and late defects. You can learn like this. Earliest field defect is an exam question. We have learned this. Let's make the field. So if this is the chart, These are the different, this is the horizontal meridians and vertical meridians, and we will know that, so this is suppose your blind spot between the 10 to 20 degree eye socket. What will be the first field effect? First field effect will be, as I told you, because it is the inferior-temporal fibers which are damaged first. Always arcuate fibers it is the inferior one which is damaged first. That is why there is notching on the inferior rim, right? And that is why, do you all also remember, the ISNT rule is broken. Don't forget the ISNT rule. This is the reason I am going to get the paracentral scotomas, the superior nasal quadrant, isn't it? If the blind spot is here, this is temporal, this is nasal. It's all, field is always opposite of anatomy. Remember? So, first earliest field effect kya hoga? This is a very important exam question you should answer. It is central or paracentral scotomas in the, so we are making paracentral scotomas generally on the superior nasal part in the Jerum's area. This area is what is called, what is Jerum's area? Area corresponding to the arcuate fiber. So this type of thing, when it is joining a paracentral, this is what is sickle shaped, and this sickle shaped is what is called sedal scotoma. Okay? So this becomes your sedal. Ke baad kya hoga? This is going to extend. So they are showing it independently here. So what is this one is your sedal, and then it can just extend further like this. Okay? And when it becomes like this, what is now it is called is arcuate, which is a late defect. So one is arcuate scotoma, and then this becomes a double arcuate scotoma, which is also called ring scotoma. Double arcuate is also called ring scotoma. And as I taught you that there is going to be a gap. So the gap has to be inside something like this. And when this gap is what is called, this is what is called Raynaud's nasal step. So this is a part where you are not getting that scotoma. It is because both the fibers are not aligned exactly abutting each other, right? So this is what you say Raynaud's nasal step. What they have asked you, first question was earliest field effect. Second question is what stays till last. So once, let's correct this one. So we have to make it something like this, where there is a gap here. So anyway, it should be on the nasal side, yeah. So this is your, when you say this, what you have to understand, it should be like this. This will create a gap. Now it is better. So this is double arcuate. What next you will know? Slowly as the nerve fibers are being damaged, everything is gone. Even the peripheral field is all gone. Peripheral field will be more bigger. Maybe this was central, isn't it? So when everything is gone, just before blindness, patient can see from the center and patient can see something temporally. So we will say which is staying till last is asked in the exam. We should remember it is the temporal island of vision which stays till last. Okay? This stays till last. I will repeat it very quickly. It was paracentral scotoma in the Jerum's area. It joined the blind spot. It became sedal scotoma, right? And this became a sedal scotoma. And this sedal scotoma finally is extending as arcuate scotoma and then double arcuate, which is called ring. So arcuate and double arcuate are considered mainly late findings, right? And then these are the late defects. What is left behind is central and temporal island of vision. Last में क्या रह जाता है? It is temporal island of vision is left behind. Hope it is clear. I took it fully because this is important. Now this is what you are seeing here. If you are going to carefully see, these are the different types of scotomas they are showing you. So this one is your arcuate scotoma, correct? We have just learned it. If this is the blind spot, this is how it extends, right? This is the blind spot, this one. Then if this is temporal, the blind spot has to be here, isn't it? So this is what it is showing you. So this is arcuate scotoma, can also be called Jerum's scotoma. So this is Jerum's scotoma is the other name of arcuate scotoma. Remember that. Now then we talk about what was the other. Let me see what is B slide showing you is just a paracentral scotoma, which I have already drawn for you. A paracentral scotoma in the Jerum's area. Uske baad next what we are seeing in the C slide is the sedal scotoma where it is joining the blind spot. So this paracentral, if it joins the blind spot, this whole thing is sedal. So this is what is sedal. Right? What next you are seeing here? Vahi Jerum's scotoma again. How it is extending further like this to become a Jerum's scotoma is this way. C and then becomes D. Right? So then what is next it is showing you is double arcuate. So we can see this double arcuate scotoma. Right? So this is double arcuate. Again there is a gap as you can see which is called the nasal step. When it is at the periphery, this is what is called Raynaud's nasal step here. And then of course central and temporal island of vision. But what is only left, only likha hai na, temporal stays till last, right? So this is a, when only central island of vision is there, but there is always a temporal. So it cannot be totally a tunnel or tubular vision, though we learn as a DD of tunnel or tubular vision. You may take it like this, but if you really are strict about it, then temporal stays till last. Okay, we come to the angle closure glaucoma now. Very simple. First of all, primary angle closure. Again, what is the risk of angle getting closed? What is angle? Again, peripheral space between iris and cornea. So, how can it get closed? Mainly the mechanism is a pupillary block. So, when it happens due to pupillary block, when there is nothing passing here, it is getting collected here. Now, the iris, this forms the iris Bombay, right? This bowing of iris or iris Bombay is finally going to adhere to the cornea and block the angle. So, I think this is absolutely clear. There is first the block here. This causes accumulation of aqueous behind the iris. Now, this iris is abutting to the cornea and this becomes angle closure, as you can see here. So, this is a closed angle. And suppose there is no pupillary block, but still there can be iridocorneal touch can happen due to plateau iris. We have learned this, where you have no anteriorly rotated ciliary body can lead to plateau iris, and this plateau iris can further cause blockage. Just remember this as well, right? So, what can be the risk factors for any angle closure? We have learned that it can be small eye, right, which will be more prone, then shallow anterior chambers, narrow angle, right? All these things you have to remember. And this is more common in females. Remember this as well. Okay, so once we know about this much, what is the risk factors, what is the pathogenesis and why it is happening. Why it is happening? क्या बताया? With pupillary block, without pupillary block. Without pupillary block example क्या है? Plateau iris. Okay, once we know this, next we talk about is, so this is the plateau iris, as you can see, the ciliary process anteriorly rotated. So what happens? There is a iridociliary contact. So first there is an iridociliary contact, and this is due to anteriorly rotated ciliary process, which in due course is going to cause blockage of the angle. What are you looking at? This is what is ultrasound by microscopy, telling you all the details of the anterior segment and the angle structures, right? Okay, so once we know this, what the cause is, we are next left with to understand your different, how do you learn the different stages? So we know the pathogenesis, we know the risk factors, we will come to clinical features. So clinical features, do you all remember? We have learnt as what is the staging according to natural history. Staging according to natural history. So this is important, and according to natural history, what are the stagings that you have to know? That first it will start with primary angle closure, isn't it? Suspect, primary angle closure suspect, right? That means this is a high risk. What are the findings here, the occludable angles and so on, we'll just take this. Then there will be primary angle closure and then primary angle closure glaucoma, right? And in between there can also be attacks which we will learn as primary, we will learn all this, I am just giving you a framework, acute primary angle closure, right, which is also called acute congestive glaucoma. And then what next happens is chronic glaucoma, and chronic, that is, we all know this, chronic angle closure glaucoma, and after that nothing, then we will come to the stage of absolute glaucoma where there is total damage. So these are the things we have to learn now for the angle closure. Let us see what we have in store. First of all, how to evaluate the angle. The next question oriented point I am only taking, I have not taken all the gradings, but what is asked is only being discussed in rapid revision. So I will be discussing here gonioscopy. So gonioscopy is a bimicroscopic visualization of angle, we all know that. अब बताओ किस कॉन्सेप्ट पे बेस है? You should know about the physics part. This is what is critical angle. So what is critical angle? Angle of that incident ray which is causing the other ray, not refraction, but it is perpendicular. That means the angle of refraction is perpendicular. That angle of incidence where angle of refraction is perpendicular is called critical angle. Now why I have shown this? This is exam question. What is the critical angle of cornea? The critical angle of cornea is 46 degrees. Okay? What will happen if the angle of incidence is more than the critical angle? If it is more than the critical angle, there is going to be total internal reflection. This concept you should revise first. Okay, so when there is a total internal reflection, naturally this is the problem happening in angles. That is why through slit lamp you can't see angle structures, because there is total internal reflection. Now to avoid that, now this is happening when the light goes from denser to rarer media, when the refractive index of one medium is more than going to the lighter. Now what do you do here? Because there is a total internal reflection, what we can do, because refractive index, air is taken as 1, cornea is 1.37. What you do, put a gonio lens with a more refractive index. It is not generally 1.5, it can be 1.39 also. It's not a hard fast rule that it's 1.5 also. But anyway, the concept of gonioscopy is you put a gonio lens. Now what happens, this becomes more denser and therefore the internal reflection is avoided. And also when it is going through a mirror and we are looking through a reflected mirror, we call this as indirect gonioscopy. You should know this, and I hope you all know this. Okay? So that means that if I am looking at the upper part, actually it is the lower angle. So it is reversed. That is what you have to keep in mind when we are talking about indirect gonioscopy. Acha. Now once you know this, what is the next question they have asked you is, which investigation does not require pupillary dilatation? So I hope you know that which gonioscopy does not require dilatation. Of course, anything in the angle that you are doing, you don't dilate, na? You want the pupil to be constricted so that the angle structures are clearly seen. So whether it is goniotomy, gonioscopy or any procedure, trabeculectomy, you don't want a dilated pupil. Keep that in mind. So does not require dilatation of pupil. Right? So this is one important question. Second was on gonio lens. What is the principle you should know? And what is the critical angle of cornea? Correct. Chalo. What is the next thing that we will discuss? What are the different features of this? So we already talked about what is PAC, right? So when you say primary angle closure suspect, what are the features? Very simple. Occludable angles means when there is a iridotrabecular contact, ITC, iridotrabecular contact in more than 3 quadrants, more than equal to 3 quadrants, right? So the same here for angle closure, but here no peripheral antiasynekia, intraocular pressures are normal. This is what is suspect. We are just suspecting because on gonioscopy, I am looking at some iridotrabecular contact, which are called occludable angles. But IOP is normal and there is no peripheral antiasynekia. This is suspect. This was number 1. After suspect comes your primary angle closure, where I may see antiasynekia and intraocular pressures are more. Just remember that. And if intraocular pressures are more, what can I do if this patient is in this stage? I can go for prophylactic peripheral iridotomy, and of course you know this now. This is important exam question as well, right? So they have asked you this way also, what is the treatment of choice or definitive treatment of angle closure glaucoma? We will answer peripheral iridotomy by NDR. If something like this is asked, we have to answer peripheral iridotomy by NDR. We have discussed this? Yeah. I hope you also remember that if there is no pupillary block, as in plateau iris, this PI will not work. What do we do in a plateau iris? Iridoplasty, right? So we go for photocoagulative lasers on the iris to make that configuration correct. Okay? Okay, so this was prophylactic PI, and we will control the pressures, of course, because the IOP is more. I want to put it in the normal range. That is the treatment of primary angle closure. So it was primary angle closure suspect. The second is primary angle closure. Once we know this, we come to what was the third stage? Glaucoma. Now what is acute primary angle? It is nothing. We have learned this again by making a diagram, isn't it? What are the features of acute primary angle closure glaucoma? What are the features? Let's make a diagram. So there will be of course pain, redness, right? Photophobia, blepharospasm, this always goes together. Then यहाँ लिखेंगे corneal edema, learn with me, as you can see it in the slide also. This is corneal edema, right? Then shallow anterior chamber, and this is the stage where all 360-degree angles are closed. So closed angles we will mark here. And what else? Vertically, this is very, very important. See, look here. It's here also. Vertically oval mid-dilated pupil. We will not forget that. Vertically oval mid-dilated pupil. So actually it is vertically because every time the pupil dilates, it is first vertically oval. So this is fixed and non-reacting at this stage itself. Okay? Yeah. And of course, cupping may or may not be seen. If it is recurrent attack, it may be seen as well. That is about acute congestive. So what is acute congestive now? Acute primary angle closure, where all 360-degree angle is closed and pain is so much that patient has vomiting and nausea. So this is what is your acute congestive glaucoma. And why this can happen? These are the predisposing factors. It can maybe dark or prone position. These are based on provocative tests are based on this. Any mydriasis, of course we don't want mydriasis here, it will close the angle. Emotional stress and medications, very important. This is your exam question about topiramate. Remember, topiramate can lead to edema in the ciliary body and ciliary body effusion. And also in sympathomimetics. These can precipitate your acute primary angle closure. So the name has changed. It is the same acute congestive glaucoma which is now called acute primary angle closure. Got it? Okay. What is the treatment? Of course, we will make the patient supine. And what should be the important question is, what is the treatment of choice of acute primary angle closure? Of course, to open the angle, you have to constrict the pupil, that is one thing. But don't forget, such a high pressures, there is iris ischemia. And because there is iris ischemia, therefore, the patient iris is not responding to pilocarpine. This is the reason. Start with IV mannitol. This is the treatment of choice. Either IV mannitol or acetazolamide. Once you have done this, of course you will start with pylo to open the angle. So this is definitely given. To control inflammation, I may give topical steroids. Okay, but be very careful. Steroids itself has their own hazards. And of course 10% topical glycerin is given to clear the cornea, right? Corneal edema. If needed, you may need a lens extraction because lens can be increased lens vault can be a very important cause of pupillary block. Right? So what is the part of lens which is anterior to the angles? That is vault, right? So that was about it. Now we come to what that if this patient has already had 1 or 2 attacks of acute congestive glaucoma, what are the features I can see in his eyes? And here comes your Voges triad which has been your exam question, right? So what will you see in the eyes? I am going to see 3, what is the triad, Voges triad? When there is a resolved acute primary angle closure, we will not forget, first is pigment dispersion on the cornea, right? Pigments on cornea, then glaucoma flecken. These are necrotic epithelial cells on the anterior capsule of the lens. This is glaucoma flecken. And what is the next we have learnt is iris atrophy. This is triad is what is called Voges triad after resolved APAC, acute primary angle closure, right? So this is it. Of course, Descemet's folds, there can be some cataract if there is a repeated attack, and of course, cupping may or may not be present. Now, once we know this, we are clear about this. We next talk about, see, this is the glaucoma flecken. This is what you are looking at, glaucoma flecken. What was the next stage after this? Of course, first. So that was in between attack and after PSCS, PSC, I told you it was glaucoma. Once I use the term glaucoma, there has to be damage of the optic nerve. Pressures are high, angles are occludable, means I told you more than 3 quadrants of iridotrabecular contact. Next we talk about what will be the stages, chronic glaucoma. Chronic may very easy to learn, all the features of open angle that you learn, field changes, fundus changes and of course IOP changes, but on gonioscopy it is closed angle or closing creeping angle closure. Okay? So this is what you have to understand. And how do you diagnose, more confirm that this is actually a chronic angle closure? How do we confirm? Of course, gonioscopy is a very big sign. Apart from that, we can also go for these tests. These are provocative tests. So, DRPPT is nothing but dark room prone provocative test. So, you are making the patient sit and lie prone in the dark room and you are trying to see the difference of intraocular pressures. Any provocative test, pressures of more than 8, just remember more than equal to 8 is significant. Okay? And this is especially helpful if the patient already has a peripheral iodotomy, but still if there is an increase of intraocular pressure, it is diagnostic that this is plateau iris. So once this is done, we next talk about is secondary glaucomas, that was primary. Secondary glaucomas, what we have to know is few very important which needs a mention in the revision process. We will take that. First is pigmentary. Do you remember pigmentary glaucoma were generally seen in the young males? right? What did we learn? It is more precipitated after any exercise. Generally, the patients are myopes. Why it is happening? Pigment from the iris is dispersing, right? And when it is flowing through the aqueous, it is blocking the trabecular meshwork. If the pigment is moving from here, more light will flow. This is what is called trans-illumination defect that you are seeing in the slide is trans-illumination defect. Then what else? We see if these pigments are deposited at the back of the cornea. Now what do you call this is Krukenberg spindles. They are spindle shaped Krukenberg spindles. Okay? So trans-illumination defects, Krukenberg spindles, very important signs which will tell me, okay, this is a case of pigment. Suddenly there is a rise of pressure after exercise. Why it is happening? Rubbing of the iris with the suspensory ligament, isn't it? So this rubbing of the iris with the suspensory ligament. The pigment layer is just at the back of the iris. Okay, so that was one, that is your pigmentary glaucoma. This is the second one. What is this? You are looking at pseudo-exfoliation syndrome. We all know what is the story. It is mainly the proteinaceous secretions deposited on the anterior capsule of the lens, suspensory ligaments. That is why you call it glaucoma capsulaire. What do you see here? This is all what is called hoarfrost sign, this deposition on the anterior capsule. Take second next question is that this is the most common secondary glaucoma. Krukenberg spindles again is also a feature in this case. What else we see is a lot of pupillary, dandruff-like deposits also seen at the pupillary border. These dandruff-like deposits are significant of pseudo-exfoliation syndrome. Okay? And all these are blocking, here pigment is blocking the trabecular meshwork, here dandruff-like material is blocking the trabecular meshwork. So both are secondary open angle glaucomas. We come to the next. The third secondary glaucoma which needs a mention is this one. Look at this. What is it? You can see the new blood vessels, right? So we are talking about neovascular glaucoma. Now neovascular glaucoma, what is the story? Any hypoxia, the basic problem lies in the retina. So the basic problem lies in the retina. So any hypoxia in the retina is going to finally lead to the angiogenic factors, which cause neovascularization. These chemotactic factors, VEGF being the main factor, is going to travel anteriorly also. So the problem started from the retina. There was hypoxia which caused release of chemotactic factors leading to neovascularization. So first thing is neovascularization in the retina. But later when it moves further, now this is causing neovascularization in the iris, and this neovascularization in the iris is what is called rubeosus iridis. This is what you are looking at. अब क्या होगा? This rubeosus iridis is definitely going to grow into the angle, and here it will first impair the trabecular meshwork drainage. That means initially it is open angle glaucoma. So after some time what will happen? It is going to turn into angle closure when the associated fibrous tissue contracts. Okay, let's talk about the question. They have asked you what is the treatment of choice of this neovascular glaucoma. We are going to answer PRP. We will remove the root cause first, so we will answer pan-retinal photocoagulation. And of course, we cannot forget anti-VEGF agents at this stage. But first answer PRP here, because we have learned this. Any proliferative stage, first line of treatment becomes PRP. Don't forget one more important term here, pigmentary. Why there is a rubbing of the iris with the suspensory ligaments? Because the iris is more in this shape. This is called reverse glaucoma. The shape of iris is like this, so we call it reverse glaucoma. Okay. Now, when you talk about malignant, the word malignant has nothing to do with malignancy. It is difficult to treat, so we call it malignant. It is also called ciliary block glaucoma. So the story is that any intraocular surgery can complicate into ciliary block, so that aqueous instead of flowing anteriorly flows in the vitreous cavity. Ciliary block matlab one of the ciliary process touching the suspensory ligament, blocking the way it cannot go further. That is what is leading to more pressures, and this time no anti-glaucoma treatment is working. Why is the anti-glaucoma not working? Why? Because the pathology is so unique. The pathogenesis, the story is absolutely very different, right? And this will lead to very shallow anterior chamber. These 2 points will not forget. Okay? This is leading to, see, this is very shallow anterior chamber, and any post-op very shallow anterior chamber we have to suspect malignant glaucoma. So how do you treat it? This time, instead of giving it, pilocarpine is given in enclosure, but here what we are giving is atropine. Because I am using a mediatic to treat it, we also call it, do you remember, inverse glaucoma. So we give atropine, this is why we call it inverse glaucoma. What will happen? Atropine will dilate the ciliary ring. When it dilates the ciliary ring, the block opens and therefore the flow is maintained. If the patient doesn't respond, then very quick revision here, we can either make openings in the anterior hyaloid membrane by NDR. What else you learned? If nothing works, go for pars plana vitrectomy, right? So remember what is reverse glaucoma and what is inverse glaucoma. Next, yes, is glaucoma associated with uveitis. So very simple, this one also needs a mention. You all know uveitis, anterior uveitis, there can be synechia formation or there may not. If there is any synechia formation here, which is a ring synechia, it will block the angle by blocking the pupil, right? So uveitis can lead to either angle closure glaucoma with pupillary block, or angle closure glaucoma can also be without pupillary block. And how it is so? Or it can even lead to open angle glaucoma. All types are possible. Okay? So what do you have to understand? If there is a pupillary block, this is going to lead to iris bombay, and then there is a peripheral anterior synechia. So any pupillary block, iris bombay formation, and this iris bombay formation is going to lead to peripheral anterior synechia and the angles are closed. So one cause of uveitis is this, isn't it? What is the next cause? I said open angle. How can it cause? Inflammatory cells are all blocking the trabecular mesh. Okay? Or this inflammation can lead to trabeculitis. Now this case of trabeculitis is what we learn here as Posner's-Klossman. It's an exam question. So I am mentioning it. So PSS or Posner's-Klossman is also called glaucomatocyclitic crisis. We also call it glaucomatocyclitic crisis. Correct? Matlab, that cyclitis where there is significant rise of intraocular pressure. What is actually happening in the patient is recurrent uveitis, but the pressures are so high that we are tending to misdiagnose it as angle closure and we are doing peripheral iodotomy. But after doing it is not actually working. The patient still has the red eye and more pressures. Kahan se ho raha hai? This inflammation or uveitis is actually leading to trabeculitis, which is leading to high intraocular pressures. Okay. So why it is happening? Nobody knows. So we know the risk factors. What are the risk factors? Risk factors we will learn, of course, is generally seen in young males. Number one, important finding. It can be associated with CMV infection or associated with H. pylori infection, or it could have some HLA association. All these are factors for Posner's-Klossman syndrome. Okay? Done? How will you treat is your exam question. Of course, I have to control the pressures, right? But main pathology is uveitis. I should give steroids if I have to manage it. But steroids itself cause more pressure. So what is your answer is topical steroids under anti-glaucoma cover. Okay? So we say topical steroids under anti-glaucoma cover. Okay, so you start with anti-glaucoma and then start with the steroids. Stop the steroids, continue with anti-glaucoma. That is what is called cover. Chalo. Next we talk about is congenital glaucoma. So these were important secondary glaucomas. We come to congenital. Congenital glaucoma, what you are looking out here is a big eye and large cornea. This is what is ophthalmos. Hope you remember this. And this is the corneal edema with ophthalmos that you are looking at. Right? You remember white cornea, large cornea, and what was the third one? Habs stria. So this is important question. Habs stria are horizontal. They are a feature of congenital glaucoma, whereas Vogt stria are V for V vertical, parallel to the steep axis. V for V yaad rakho. Okay? And this is seen in keratoconus. So this was one important question. Second question on congenital glaucoma has been asked about treatment. Right? So when you say treatment, what is the treatment of choice? We will answer goniotomy. Treatment of choice of congenital glaucoma. We'll go question oriented discussion only. So little quick here. So treatment of choice of congenital glaucoma, aap bologe goniotomy. Another question for you. If goniotomy needs a clear cornea, if you do not have a clear cornea, the next best answer becomes trabeculotomy, where you go through the Schelm's canal with trabeculectomy. Of course, with trabeculectomy. Okay? What is trabeculotomy? You're giving a cut both in the Scham's canal and trabecular meshwork. What is goniotomy? Only giving a cut in the trabecular meshwork. Trabeculectomy, removing a piece of the trabecular meshwork and creating a fistula. So whenever they are asking you overall also what is the treatment of choice of congenital glaucoma, if goniotomy is given, that has to be answered first. Second, we can answer this one. Okay? If they say, okay, the cornea is hazy, we can't see, there is no clear cornea, then our answer will be trabeculotomy. Right? Okay. So these were the questions around your congenital glaucoma. Now when you talk about treatment of glaucoma, when you say treatment, what should be the target IOP? How do you define that? I think we have done this. Anything which will prevent the progress of the visual field without compromising the quality of life. Visual field defect should be stopped. Correct? Now, we all know the treatment can be divided into medical, it can be laser, or it can be surgery. Right? So, medical, laser, surgery. Medical can be either topical drugs or it can be your systemic drugs. A very quick revision here. When you talk about the medical drugs, a few important exam questions se shuru karte hain. Tell me, what is the first group of drug? The first group of drug is beta blockers. What are the question asked here? It is contraindicated in asthma. You will remember this. And which is a selective beta blocker is your next question. We will answer. This is your betaxolol. We know this. The third question is that which antiglaucoma causes nasolacrimal duct obstruction? Here we are going to answer is timolol. Now comes the next group of drug is alpha agonists. Alpha agonists we all know can again be selective and non-selective. Epinephrine, dipivefrine, and brimonidine, apraclonidine. Which are selective? We all know brimonidine and apraclonidine are selective alpha agonists. What is the mechanism of action of beta blockers? Decreases formation of aqueous. And what is the mechanism of action of alpha agonists? Increases drainage also, decreases formation also. So it decreases formation and increases drainage of the aqueous. Okay, so once we know this, next question on alpha is brimonidine. Which antiglaucoma drug causes drowsiness? So we know which is the selective is brimonidine and apraclonidine, drowsiness by brimonidine. Okay, another question, brimonidine is contraindicated in children. I hope you remember. In infants, why? Because it can cause CNS depression. Then another important thing is about conjunctival pigmentation, which is again a feature of or a side effect of adrenaline. Remember that as well. So then you have to remember about conjunctival pigmentation by adrenaline. Now I am taking this here because it's very important. A lot of questions are asked on this. Right? This was about your alpha agonist. What is the third group of drug? Miotics. Miotics mein we are giving generally pilocarpine. First question, contraindicated in uveitis. Right? What is the next mechanism of action? It increases the trabecular outflow. This one is increasing the conventional or trabecular outflow. Keep this in mind. Just revise from the lecture what are the disadvantages of using pilocarpine, how it can lead to accommodation spars, myopic shifts, and shallow anterior chamber, iris cysts, and sometimes even retinal detachment. So just revise that. Next group of drug after this is your prostaglandin analogs. We all know prostaglandin analogs. First question is on mechanism of action. We will answer it increases the uveoscleral outflow, isn't it? So uveoscleral outflow, right? So once increases the uveoscleral, so what is the next question? Next question was about, yeah, of course names you all know, latanoprost, bimetoprost, travoprost, uniprostone isopropyl, and so on. Okay. Another question, it is also contraindicated in uveitis. Then which antiglaucoma causes heterochromia iridis? Again we know it is latanoprost. And then they asked you that which will increase both outflow, increases both outflow, we will answer is bimetoprost. It is bimetoprost, right? What is the next group of drug? It is topical C inhibitors. So they have asked, of course, topical C inhibitors, what will mechanism is it decreases the formation of aqueous, decreases the formation of aqueous. And topical C inhibitor, question is what are the names? I hope you know, it is brinzolamide and dorzolamide. Right? So it is dorzolamide or brinzolamide. Okay. Once we know this, what is the next question they've asked you? Contraindicated in sulfa allergies. Don't forget this question. Right? In sulfa. Because these are all sulfonamides contraindicated in sulfa allergies. Systemic drug again. So what is the next group of drug is? RHO kinase inhibitor. Rho kinase inhibitors. Right? And what is the name? We all know we are talking about is nitarsodil. This is the one which has been asked. We'll revise this one. Nitarsodil increases mainly the trabecular outflow. We will remember this important point. And second important point, it can lead to vortex keratopathy. You all know it is cornea vorticillata. A vortex keratopathy is deposition of the drug in a whirl-like manner. Yeah, na? Chalo. Up next was your systemic drugs. Systemic we will learn one is oral C inhibitor and we know the name is acetazolamide. We will remember it is also contraindicated in sulfa allergies. Acetazolamide, systemic have their own problems like tingling sensation and all, you should know this. Then hyperosmotic agents, we all know, which will dehydrate the vitreous, decrease the pressure. What are the hyperosmotic? Isosorbide, urea, mannitol, glycerol, which are commonly given, right? Okay, so once we know this, we can now come to the next slide here. So this is what you are looking at is heterochromia iridis due to latanoprost. So the latanoprost has been given in this eye, the darker color, which causes iris pigmentation. So iris pigmentation, it is latanoprost. Conjunctival pigmentation is adrenaline. Don't forget that. Okay. Then we talk, so be careful. So here comes your deposits of pigmentations. This is your adrenaline or epinephrine. We also call it epinephrine. Right? So this is another side effect of this. What is this? This is what we are learning as vortex keratopathy. This is the side effect of nitarsodil. What are the other causes of vortex keratopathy? Very quickly. I hope you all know this. This chloroquine. Then we will answer amiodarone. And then we answer tamoxifen. Fabry's disease, indomethacin. All these you should remember. Hai na? And what else? What about chlorpromazine? No. Okay. It is mainly deposited in the endothelium layer of the cornea. So we won't answer chlorpromazine. And what was the next thing was laser treatment, right? So laser treatment, again I am making your life simple. It can be open angle or angle closure. So write like this, open angle or angle closure. Kya padha tha? If it is angle closure, naturally we are going to do peripheral iridotomy by NDI, or if it is a plateau iris, we know we go for laser iridoplasty. I just mentioned this, I suppose, right? What was the next? When you say open angle, we have to do trabeculoplasty. And trabeculoplasty, we are giving coagulative lasers on the trabecular meshwork to open the angle. This can be given in 3 ways that you have to remember, whether it is argon laser trabeculoplasty, or we are using the yellow Nd:ARC, that is double frequency Nd:ARC, that is called selective laser trabeculoplasty, SLT, or it could be micropulse laser trabeculoplasty, right? Generally micropulse diode. So these are the 3 types of trabeculoplasty. Just remember, this is one indication. Okay? So laser, open angle, angle closure, these are the indications. So simple. And of course, we can't forget absolute glaucoma, where the choice of treatment is this ablation of the ciliary body. This is the choice of treatment in absolute glaucoma. Either we do it transscleral or we go for endoscopic, but this is cyclophotocoagulation. So cyclophotocoagulation is the choice of treatment where you damage the ciliary processes so that aqueous form few ciliary processes. So that aqueous is formed less and pressures are controlled. Because absolute glaucoma is a painful blind eye. As you know, that was after chronic, we had to mention that. So it's a painful blind eye and it's a refractive stage, not responding to any anti-glaucoma treatment. Then we are doing this because it's already a blind eye. We want to decrease the pressure, so we go to and damage some ciliary processes. That is what is cyclophotocoagulation. Cyclophotocoagulation can be due to, we are doing it either cryo or we are doing it through laser, right? That is called photocoagulation. Cyclotherapy can be cryo or through laser photocoagulation. Yeah. So it is generally a diode laser, don't forget that. So we call it DLCP, diode laser. These are the lasers, we have learned this. And next we have different surgeries. Surgical treatment, don't forget, it can be either non-penetrating, just know the names, they haven't asked you to detail at all. So it can be deep sclerectomy or viscocanalostomy. Penetrating, yes, what they have asked you is trabeculotomy. MIGS, minimal incision glaucoma surgeries. We all know this, that in this, generally done along with the cataract surgery. If it is mild to moderate glaucoma, we can control through some other bypass implants. Okay? So let us go question oriented. First we talk about trabeculectomy. They have asked you which antimitotic drugs can be used in trabeculectomy. If you have forgotten the method, please look at the lecture how to go for trabeculectomy. So which antimitotic? We remember mitomycin C and 5-fluorouracil. Okay? We are making a fistula between the anterior chamber and subconjunctival space. Next question. They have asked you about express implant, right? So express implant is generally done during the trabeculectomy procedure. What are they made up of? We will answer titanium. Earlier we used to answer stainless steel. So many places they have written stainless steel, but now we'll answer titanium. And of course, the most commonly used bypass stents that we are using is your Ahmed glaucoma valve. Satin surgery mein, what we say, Ahmed glaucoma valve. These are the questions for trabeculectomy. Let's see. Yes. So this is your goniotomy, cutting through the angle. We need a clear cornea for this to pass the needle from one angle to another. This is the goniotomy knife or needle, right? So we have to pass from one angle, not needle, sorry, this is knife. So goniotomy knife from one, it's almost like a needle, from one limbus to another. ठीक है? अब ये यहाँ पे मैंने क्यों include किया? Because हमें ये नहीं भूलना है that this is actually a treatment of choice of congenital glaucoma. This is the reason. The same thing is being shown here, more clearer view. How you are going through like this and then you make a sweeping movement like this. Look at the arrow to cut through the trabecular meshwork. This is goniotomy. And then we have next what we will discuss. Of course, when you have making a fistula and covering everything with the conjunctiva, if your fistula is working, there will be a bleb. So presence of bleb tells you the success of the procedure. This is what is a bleb. Okay? This means that the fistula is working. This is what we mean. Okay, then we talk about next is, here we see the same Ahmed glaucoma valve being one of the most commonly used during trabeculectomy. Aqueous drainage implant most commonly uses Ahmed glaucoma valve, right? This is the aqueous drainage implant. Okay, so that was a very quick revision for glaucoma. Okay, let's talk about cornea now. Give the heading cornea. What are the layers of the cornea? Let us quickly revise this. Let's make a diagram for ourselves. First is your epithelium. As you can see, it is not a single layer, but it is multi-layered, right? We have basal cells, wing cells, and then the stratified squamous epithelium, right? So, this is one. Then, second is your Bowman's membrane. Third is stroma, Descemet's membrane, right? And finally comes your endothelium. Okay, so this much we know. What is the next thing we have to know? A recently discovered layer just between the stroma and the descements. This is what is Dua's layer. It is considered the strongest layer of the cornea, right? So this becomes the sixth layer. We don't number it like this, but just telling you. After this, what you have to know is that next discussion is question based. Let's remind ourselves. Epithelium, what type? So it is squamous, stratified and non-keratinized. Okay, note it down. That is the one question. Non-keratinized, stratified squamous epithelium. Okay, once we know this, this is one question and one is your Dua's layer. Okay, so we will remind ourselves with this histology picture also. Sometimes they ask you. So this is the endothelium, descements, stroma, Bowman's and epithelium. Talking about the physiology, what you have to understand, point number one is that cornea is avascular except at the limbus, but it is considered avascular otherwise. We should also know that what is the primary metabolism. In lens it was anaerobic. Cornea we will learn is aerobic metabolism. Right? We know this? Okay, so when you say aerobic metabolism, what is the question here asked is, the question primary, both are there, but primary is aerobic. From where does it get its oxygen? We all know it is from the air and nutrition from aqueous humor. This is simple? Yeah. What else? Then they have asked you this, that why do you get a corneal edema? Okay, let's first talk about detail in physiology and then we'll talk about this question. So, what is the next important thing is that cornea is dehydrated. And why it is dehydrated, though it is totally surrounded by water, how this is possible? We all know because of not only the barrier function of endothelium, one is barrier function and what is the second? Pump function. So, it has got a sodium potassium ATPase pump and this is what is pumping the water back into the aqueous, right? Since this sodium potassium ATPase pump pumps the water back into the aqueous. This is the reason why cornea is in a dehydrated state and why it is so important for it to be dehydrated. We all know very well. This is to maintain the transparency of the cornea, right? Okay, so We should also know that these endothelial cells do not regenerate, right? So they do not regenerate. What are the other layers which do not regenerate? The Bowman's membrane and stroma. Outermost layer of the stroma is the Bowman's membrane, right? So first, do not regenerate. First we will answer this exam question, endothelium as the first option. Other options can be Bowman's membrane and lastly stroma. These are the layers which do not regenerate. Now that is the reason endothelium is playing such an important role. So the number of endothelial cells becomes very important. So next question, normal number in adults is 2500 to 3500 cells per millimeter square. Okay, not cube, it is per millimeter square. Just remember that, right? Okay, so once we know this, it is actually 2500 to 3000, not 3500, 3000 cells per millimeter square. Okay? Once we know this, then we talk about that what happens is, let's go back to this our diagram. So endothelial cell have the function of maintaining the cornea in a dehydrated state. But if what happens if one endothelial is damaged, the adjacent cells is going to cover the space. It is also going to take up the function of the damaged cells, right? This much we know. Now this compensation will have a limit. So this is what is asked in your exam, what is the limit? You already know the normal number of cells. Limit is when it goes less than 500 cells per millimeter square. If it goes less than 500 cells, now it cannot maintain the dehydrated state, there is hydration. Hydration will lead to number one, stromal hydration. This is the water in the stroma. Slowly it is epithelial hydration, and more worse will be when bulli filled with fluid are formed. This is what is called bullous keratopathy. We know this. And therefore, when there is no compensation, what do you call? This is corneal decompensation. So bullous keratopathy is a sign of corneal decompensation. It should be very, very clear to you. That's why I have described the whole thing. So what they have asked you is the number of cells that is required. And a graph that should be recommended is up to 1500 to 2000 cells should be there in a corneal graph for us to use it. That is another question. Okay. Then the question on less than 500 cells has been asked. Right. So this basic physiology, these are the points that we have to know very well. Right. Okay. The next question they have asked you on this is that what are the organisms which can penetrate intact epithelium? So you should be very, very clear when we say organisms which can penetrate intact epithelium, we are talking about not the whole cornea but only epithelial layer. Okay. So normally what happens? That generally this infection will happen only when there is an ulcer, right? But organisms that can penetrate intact epithelium, this is what we are discussing. So we will learn it as NNLDH. Okay, LDH we all know, NNLDH, and at the end we add an S. So what is NNLDH? Very simple, both the Neiserias, that is Neisseria gonorrhea, Neisseria meningitis. You know this, right? We have learnt it. What else? Listeria. Then we have talked about diphtheria, Haemophilus and Shigella. Okay. So these are the organisms which can penetrate intact epithelium. So this has been your exam question. So we are learning this. After this, next thing they have asked you a few questions on investigation, right? So very quickly, investigation, we all know what is keratometry. Keratometry, I am not writing. Keratometry, corneal curvature. Corneal topography, again corneal curvature, where it is scanning the whole cornea. So keratometry, I have explained you all. We only take the central 4 millimeter optic zone. This only when this is scanned, this is your keratometry. But when the whole cornea is scanned, now we call it, we will say this is what is corneal topography, which is based on principle of Placido's disc, right? And what is then pentacam? That is tomography, corneal tomography, where we are taking the curvature of both anterior and posterior surface of the cornea, right? So that becomes a corneal tomography, which is called pentacam. So we should know what are the measurements in the pentacam. They have not asked you this, so I am not going in detail. You can check your lectures. So what are the questions next asked? Yes. What is this? Pachymetry. So next question they have asked you, what is pachymetry? We all know pachymetry is to measure the thickness of the cornea, right? To measure the thickness of cornea is pachymetry. What is this? This is what is exam question which is repeated. This is specular microscopy. So they have asked you what is specular microscopy. We will say this is your examining the endothelial cells. So we are not only seeing the endothelial number, we are also seeing how many cells have undergone any polymegathism or pleomorphism, right? So this is how we look at the cells. These are the endothelial cells seen on specular microscopy, right? Polygonal in shape. Okay. Once we know this, the next thing that you have to learn in cornea is keratitis. We all know keratitis is inflammation of the cornea. It can be bacterial, fungal, viral, acanthamoebal or interstitial. This is what we are going to quickly revise now. What again, question oriented, what are the things they have asked. So first is your bacterial keratitis. What are the questions? You all know bacterial keratitis again is you are getting an ulcer here which is fluorescein stain positive. What you otherwise also get here is, as you can see, is hypopyon. Right? Of course, we all know that all types of keratitis, the patient presents with pain, redness, photophobia, blepharospasm, discharge, diminution of vision. So this fits everywhere. So what is different? That is what they ask you and that is what we have to learn. What is different, right? Okay? Okay. So what is the first thing they will ask you here is what type of hypopyon? So it is always a sterile hypopyon when you are talking about bacterial keratitis. Second question is most common bacteria infecting the cornea. We will answer Staph aureus, but if they are particularly asking for India we can answer Staph epidermidis. Next question they have asked you after this is about where do you get hypopyon corneal ulcer. This term is mainly used for the ulcer due to pneumococcus because it is always associated with hypopyon, right? What is another name of the ulcer due to pneumococcus apart from this is we also call it ulcus serpens because it is spreading in a serpentine manner, right? So we also call it ulcus serpens like this, okay? So these are some important points regarding bacterial keratitis that we have to keep in mind. Of course, investigation, Gram stain, Giemsa stain, you all know that. And treatment would be antibiotic eye drops and we will of course any keratitis is associated with uveitis, so we always give atropine, right? Then of course we can always go for other drug like lubricating eye drops, it help the epithelium to grow, vitamin A, vitamin C again helps the epithelium to regrow and heal the ulcer area. But our prime treatment would be of course antibiotics, right? It can be broad spectrum, it can be culture sensitivity. What questions they have asked you is only around these things. Yes, one more question was that where that pseudocornea is a feature of. So we have to answer pseudocornea is a feature of, let's note down here, pseudocornea is a feature of, I am writing here, is you will say, tell me, it is sloughing corneal ulcer. So we have learned now that any bacterial ulcer can be sloughing, it can be perforating or it can be just a localized ulcer which will heal. So when you say perforating, how do you generally manage that and how do you treat the small perforations? I hope you know we go for cyanoacrylate glue. So that is another thing you have to know about perforating corneal ulcer. Perforating corneal ulcers can lead to leukoma adherence. Leukoma is opacity, adherence means because it won't remain open. The iris will come from behind and seal the perforation. That is called leukoma adherence. Okay, and this is what is your sloughing corneal ulcer में क्या मिलता है pseudocornea. And do we remember pseudocornea can be a very important cause of anterior staphyloma. Okay, don't forget that. So any pseudocornea can later lead to anterior staphyloma. Right, I think, and how do you manage this? Cyanoacrylate glue. Yeah, there was one more question about which bacterial keratitis is resembling a fungal keratitis and the answer was nocardia. So nocardia you have to remember can resemble a fungal picture, resembles fungal keratitis. Anything else? I think, yeah, one more. Which bacteria can cause corneal perforation within 48 hours? This was another question for you all. We will answer Pseudomonas. So these are the questions on bacterial keratitis. Okay? Pseudomonas, where else do we learn? Let's not forget most common infection after contact lens use. Most common infection after contact lens use, we will answer Pseudomonas. We come to the next keratitis and this is what do you see? I can see some hyphae here. So we are looking at keratomycosis, that is your fungal corneal ulcer. So what did we learn in fungal corneal ulcer? That the ulcer has dry and rough look, okay, and projecting ends, these are hyphae. We had made the diagram also. You can get some hypopyon. If you get a hypopyon, it is always unsterile exam question, right? Keep in mind. We may also get some smaller lesions away from the main lesions. This is a repeated question. These are called satellite nodules. So these can be the findings of fungal keratitis. These are important cues. Okay? What are the other questions? Another thing they have asked you is what is the most common fungus causing your keratitis, most common is Aspergillus fumigatus. Right? We should know this. These are all factual questions, so we can be quick in this. If this option is not given, the second best option we will answer is Fusarium. Right? Then which is the most common fungus infecting lids? If they ask you, then it is Candida albicans. Lids, we will answer Candida albicans. And you remember your orbit? Mucormycosis. Endophthalmitis, again Candida albicans. So everything we have revised. Then what else they ask you is, why do you get a fungal keratitis? This has been even recently asked, important question. It is trauma by vegetative matter or organic matter. Trauma by vegetative or organic matter. And another important point to remember for fungal is that signs are more than symptoms. I am comparing with bacterial keratitis. Signs are more than symptoms. And the last question here is, what is the treatment of choice? We will not forget natamycin. How much percent? 5% natamycin. It is most effective against Aspergillus. We come to the next slide here. What are we looking at? We are looking at, this is all fluorescein stains, superficial punctate keratitis. So, it could be herpes simplex, it could be herpes zoster. So, we are talking about viral keratitis. Which is more common? First question, simplex is always more common than herpes zoster ophthalmicus. What is the other name of herpes zoster ophthalmicus? Shingles. We call it shingles. Correct? Okay, what is the next question? What is the pathognomic feature of viral keratitis? Pathognomic feature is, don't say dendritic ulcer, a commonest mistake. Dendritic ulcer is not a feature of zoster. Therefore, what is the answer? Decreased corneal sensation. Right? Then we should also know about what are the causes of decreased corneal sensation. Tell me. We should answer diabetes, leprosy. Along with viral keratitis, these should never be forgotten. Right. What is this? The next thing that we are looking here is your dendritic ulcer, right? We all know dendritic ulcer typically has knobbed ends. This is asked in the exam. It has knobbed ends. And it is a feature of herpes simplex infection. Another important question, steroids are contraindicated in dendritic ulcer. We all know this. This is all epithelial involvement of simplex. It can later lead to what? Geographical ulcer, right? So, this is what is a geographical ulcer. It can also call corneal perforation, but mainly this is geographical ulcer in herpes simplex. Okay? Then zoster. We all know zoster infection, there can be three primary things that you have to remember. That is your eye involvement, then your skin involvement and trigeminal neuralgia. Isn't it? So, what is the first question in zoster? They have asked you what is Hutchison's rule. You see, this is the skin involvement which is respecting the midline. It will not cross the other side. It is all again along the distribution of trigeminal nerve. Trigeminal nerve. Okay? Okay. Then what is Hutchison's rule? Hutchison's rule says that if the tip of the nose is involved, eye will be involved. If the tip of nose is involved, then eye will be involved. Why? This is due to involvement of nasociliary nerve. Correct? Okay. Again, if you quickly take about what are the involvement in zoster. So, what do you get on the epithelial side? What are these? Are these dendritic ulcers? No, it doesn't have a knobbed end. So, these are pseudodendrites. So, we will remember pseudodendrites as a feature of herpes zoster. Right? So, if you remember how we learned, there were pseudodendrites in the epithelium. What did you get in the stroma? The circular coin-shaped lesions. What are these known as? These are nummular keratitis. This is also exam question. This is a nummular keratitis. Right? So, nummular keratitis again is a feature of zoster. And endothelium, both in zoster and simplex, do you remember what we had drawn? Disciform keratitis. Endothelitis in a disc-shaped manner is disciform. Okay. Okay, one more question is reminded. Disciform generally can also be a part of direct infection, but a part of hypersensitivity reaction. If it is so, what type of hypersensitivity reaction it is? We are going to say it is type 4 hypersensitivity reaction. It is a type 4 hypersensitivity reaction. And of course, we will not forget when you talk about treatment of the zoster, apart from the acyclovir simplex, so what do you give? Only topical antivirals are enough. Right? What are the topical antivirals? We are going to give 3% acyclovir eye ointment 5 times a day. But if you are talking about zoster, we should also go for oral treatment. Right? And should we also not remember this, that all these treatments are required only for 14 days. If you are over treating, it will lead to metaherpetic keratitis. It will lead to metaherpetic keratitis. What is that? This is keratitis due to toxicity of the antivirals, right? So this is what is, you stop the drug and start with lubricating eye drops. So this is due to toxicity of antivirals. So these are the important points regarding viral keratitis. We next talk about, which is this one. Can you see the ring lesion? We are talking about acanthamoeba keratitis. So first question is, it is a rare infection. Therefore, when does it occur? We all know it is soft contact lens users if they are washing their lenses with tap water. So if they ask you most common infection of contact lens use, please don't answer acanthamoeba. Most common is Pseudomonas. But yes, acanthamoeba also occurs in soft contact lens users. It's not a very common infection. Second important point, of course, it can present as a ring lesion, and very important, pain is disproportionately much more. Because it invades the nerves, it is causing perineuritis. Okay, it causes perineuritis. This can also lead to thickening of corneal nerves. This is another important point. Next thing they have asked you about this is, what is the culture media in acanthamoeba? So culture media we will learn is non-nutrient agar with E. coli, right? And we will not forget the staining also, chalcofluor white or acridine orange. So these are few strains, but what they have asked you, the question, that's what I am writing here. So that was culture media. Then what else? Then they have asked you about the treatment of choice. So the drug of choice will be PHMB, polyhexamethylene bigonides. We'll remember this. Let's talk about the next. The next slide, as you can see, epithelium and endothelium are not involved, only the stroma is involved. What is this? Interstitial keratitis. When epithelium and endothelium are normal and only stroma is involved, this is your stromal keratitis, is called interstitial keratitis. So interstitial keratitis, we know all the causes can be syphilis, it can be tuberculosis, leprosy, sarcoidosis, remember all that, okay? And don't forget Cogan syndrome. What is Cogan syndrome? Cogan syndrome is interstitial keratitis with deafness. Okay, what they have asked you, the question is this one. Salmon patch is a feature of, a patch of bleeding in the stroma. This is what is salmon patch. This is a feature of, you will answer, syphilis. This is the question of interstitial keratitis, right? Next we talk about is, what is this? The next condition, it's an ectatic dystrophy of the cornea. We are talking about keratoconus. What are the points to remember? Keratoconus, it is a genetic disease, slowly progressive. Because of the irregularity of the cornea, the main issue becomes irregular astigmatism. Because of this irregular astigmatism, there is marked diminution of vision, decreased visual acuity, right? Okay, so this you have to remember. Now, what are the different signs? It's very important to revise that. What are the other questions they have asked you in keratoconus? So, keratoconus, what is this? This is in one sign. This is called Munson sign, where there is a V-shaped deformity of the lower lid. This is your Munson sign. This is what is Fleischer's ring, which is nothing but iron deposition at the base of the cone. This is not case of Fleischer, it is only Fleischer's ring. And Fleischer's ring is mainly seen where? We will answer epithelium. It is the iron is always, all the irons are deposited in epithelium, keep in mind, okay? Yeah. Then what are the other signs we have to look at? This is what is called oil droplet reflex. This is oil droplet reflex. You all remember oil droplet cataract? Almost looks similarly, but that was cataract in galactosemia. So the background history will help you to diagnose. This is oil droplet reflex. And what was oil globule reflex? That's also discussed. That is in anterior lenticonus. So these are the three oils you have to know. Very important, oil droplet reflex kaise dikhta hai? Is it a slit lamp finding? No. It is seen under distant direct ophthalmoscopy. Please remember, you know now when direct ophthalmoscope is seen at a distance. What distance do we see? They have asked you, it is 25 centimeters we see, na? So distant direct ophthalmoscopy. It is done at 25 centimeters. Okay? So these are some important signs, and then we see what else you are getting in keratoconus is, this is another, I have just picked up mainly the signs which have been asked in your exams, okay, important ones. So this is your prominent corneal nerves. Prominent corneal nerves, please remember, is due to thinning of cornea and not due to thickening of nerves. What are the causes of thickening of nerves? Thickening of nerves, we will answer, is due to leprosy and NF1. Leprosy, NF1, I just also mentioned your acanthamoeba causing your perineuritis. These are the causes of thickening of corneal nerves. But here what is happening is thinning of the cornea. This is the reason of prominency, thinning of cornea. Please remember this because this is exam question, right? Then they have also asked you one more, I'll mention here only, is what is scissors reflex. This is a finding of retinoscopy, okay? In keratoconus, the two light reflexes are seen as two blades of a scissor. This is what is called scissors reflex. This is also exam question. Another question is what is the treatment of choice? If we talk about a progressive type of keratoconus, then the treatment of choice would be C3R. We all know what is C3R? We put riboflavin and we expose the cornea to ultraviolet A rays. This is corneal collagen cross-linking with riboflavin. Okay. So, especially for the progressive type, we have to say this. Sometimes they ask you what is the treatment of choice, what is the type of contact lens which we should use. I think we all know this. It is rigid gas permeable. Why? So, if this is the keratoconus and if you are putting a soft lens, it takes the shape of the cornea. So, if I want to make a difference, I should use something which will replace it with regular surface. Therefore, we should use RGP lenses. Okay? So, always say RGP lenses. So, these are some important points regarding keratoconus. After this, we will talk about is keratoplasty. We all know that the definitive treatment of keratoconus is also penetrating keratoplasty, isn't it? So, what are the questions they have asked you in keratoplasty? So, in keratoconus also we may start with specs, but very soon contact lens, then C3R treatment, and then of course we can even talk about intacts, which are the intracorneal rings, especially for eccentric keratoconus, and we, of course nothing else helping, then we go for penetrating keratoplasty. Keep this in mind. Acha, intacts also keep in mind, they have asked you once, right? Intracorneal rings for treatment of keratoconus, right? This is also very important. We will keep this also in mind. Then we talk about when you say keratoplasty, we all know this is what is corneal donation or eye donation or corneal transplantation. First question here we all know is that from where we are getting the cornea is a cadaveric eye. Next question they have asked you is within how many hours? Ideally within 6 hours. You may extend it to 12, but ideally within 6 hours. Of course, I am going to check the cornea. I'll see the endothelium cells should be more than 1500 to 2000 cells per millimeter square. Don't forget that, right? Apart from that, I'll screen for other diseases. I'll do the blood test and then only I'll decide to put it on the patient, right? Okay. Then another question they've asked you, what is the most common infection after keratoplasty? So, after keratoplasty, we will answer staph epidermidis. Okay? Staph epidermidis. Then they have also asked you what should be the size of the graft. It should be at least 0.25 more than that of the recipient. Okay. So, the donor graft is ranging anything around 7.5 mm. So, the graft size generally is 7.5 mm. Then they have asked you about your graft rejection signs. So, we will not forget the endothelial. The one that they have been asking you is about the Koda-Dost line. What is Koda-Dost line? This is endothelial graft rejection. Endothelial graft rejection. And what are Crackmer spots? Crackmer spots are mainly subepithelial. Okay, these are subepithelial are Crackmer spots. And epithelials are called, epithelial infiltrations are called case dot. Just be familiar with the names. These are all signs of graft rejection. These are signs of graft rejection. So, let's see, any keratoplasty can be classified as, it can be either full thickness which is penetrating or it can be partial thickness that is lamellar, right. So, when you talk about the lamella can be of two types. Lamellar keratoplasty, very quickly I hope you all know this, that it can either be deep anterior lamellar keratoplasty. Anterior lamellar can be superficial or deep, so it can be anterior or it can be posterior lamellar keratoplasty. If you are taking the stroma and replacing it, little bit of stroma is involved, what do you call that? Let's see this slide, it will be more clear. So, look at this shaded area. So, if all this is replaced, total thickness, this is what is called penetrating keratoplasty. These are the layers of the cornea which are being shown. Now, when you are replacing the endothelium and a very small part of the stroma is also involved, this is what is deep lamellar endothelial keratoplasty. I told you, posterior endothelial keratoplasty with little bit of stroma. So, that amount of stroma keeps on decreasing as we have gone through. So, this is deep lamellar ka hi type hai, that is called Descemet stripping endothelial keratoplasty, where a very minimal stroma is disturbed, and when no stroma is disturbed, we call it Descemet's membrane endothelial keratoplasty. Okay? So, I will just explain you again here. What I am trying to tell you here is, if this is your anterior lamellar keratoplasty, we all know this, I think we have done this in the lectures, a quick revision only here. So anterior lamellar keratoplasty, we are removing anterior part but not disturbing the little bit of stroma, the endothelium and Descemet's membrane is left behind. Because any disturbance of the endothelial cells, that will be a high rate of graft rejection. Okay. So now it can also be superficial, less than 1/3 I am replacing, we call it superficial lamellar, anterior lamellar keratoplasty, or I can call it deep anterior lamellar keratoplasty when it is more than 1/3 which is replaced. Superficial like in limbal dermoids or pterygium. Correct? Clear? Now we come to posterior lamellar, which is also called deep endothelial lamellar keratoplasty. This is not posterior lamellar, it is mainly called deep endothelial lamellar keratoplasty. So the second type, this was anterior lamellar keratoplasty and this is endothelial keratoplasty. This endothelial I am saying can either be Descemet stripping endothelial keratoplasty where some stroma is involved, but Descemet's membrane endothelial keratoplasty, no stroma involvement, okay, no stroma is disturbed. Just this much you have to know. Okay, DELK itself can be DSEK or DMEK. They have shown here separately, but it is just an evolution. Initially more stroma, then minimum stroma this, but we will learn like this only. Then, so this was about your keratoplasty. And what was the question? Why I am discussing all this today here in rapid revision? Question was on DSEK. Okay, so you should know what is DSEK. Right. Then we talk about the clinical signs of graft rejection. I have already discussed with you that corneal edema, KPs and signs of inflammation, vascularization, these are common. We should know what is Koda dos line. Epithelial is case dot, subepithelial I told you is Crackmer spots, isn't it? So this we have done. Okay, after this we come to the next slide. What is this? We all know this, we are talking about corneal degeneration. This is the one asked in the exam. Arcus senilis. Arcus senilis in old age, this is what? This is lipid deposition. Lipid deposition in stroma. Okay? It starts again superiorly, inferiorly and then it will become a circle. Remember that. Just like we have learned in case of Fleischer. Right? And what was juvenilis? Which is happening in hyperlipidemia, it is before the old age. Right? Okay. And what is this clear space between the limbus and the arcus? This is arcus, this is limbus. Can you see the black strip? That black strip is the clear space. I hope you remember. This is what is called lucid interval of Vogt. Okay, so this was your arcus senilis. Next degeneration they will ask you is this one, very important. You can see it's a band-shaped deposition of what? Calcium. Where is the calcium deposited? It is generally subepithelial. It can be on the Bowman's membrane. It can be also on the anterior stroma. What do you call it? Band-shaped keratopathy. Exam question here, which is the most common cause? We know it is idiopathic. What are the other causes? Chronic uveitis in children suffering from JRA. It can be phthisis bulbi and hypercalcemia. So next question is related to hypercalcemia. Because it is present in hypercalcemia, it can be seen in sarcoidosis. We will not forget these questions. Another question is treatment. So, how do you treat band shape? We answer chelation with EDTA. Chelation with EDTA. Okay? So, that was about this degeneration. What is the next we will talk about here is corneal opacities. And when you talk about corneal opacities are of three types, isn't it? Nebular, if you look at here, is very superficial, less than 1/3 involved. 1/3 to 2/3 it is macular and full thickness involvement of is what is called leucoma. Okay, so if this is your cornea, if little bit is involved, this is nebular. Then I am saying if more than that, this is macular, and if full thickness, this is what is leucoma. You all know this. So this was important at your level. They ask you which opacity will diminish the vision most. I think we all know nebula will cause maximum diminution of vision because of the scattering of light. It is going to interfere even with the function of normal cornea, clear cornea as well, right? So if this is the opacity here, because of the scattering, it is disturbing the whole cornea. But when I talk about leucoma, it is only obstructing the light, so the rest of the corneal function is not disturbed. It just obstructs the light. This is the reason nebular corneal opacity diminishes the vision more than leucoma, right? So that was quick discussion on cornea. So let's quickly revise conjunctiva. So our next heading will be conjunctiva. Again, it's a factual chapter and quite easy, but a lot of questions here. Let's see. So conjunctiva, what did we learn? What are the parts of conjunctiva? Bulbar, palpebral and fornix. Inflammation is called conjunctivitis. Correct? All the conjunctivitis, generally majority of them have overlapping presentation. The patient will present with the same, that is a pain, with the 5 fingers which I generally call like pain. Pain is of course the least, I shouldn't be mentioning pain. I would say there is redness. Which type of redness? We will answer it is conjunctival congestion. Everybody remembers? So conjunctival congestion, when there is congestion of only conjunctival blood vessels which are branched, right? Then of course photophobia and blepharospasm, this will be seen if corneal involvement is there, and if there is a corneal involvement we will always also get pain is also there. So pain will be seen in severe cases, right? And discharge, of course all types of discharges. Now what can be the type of discharge? We remember it depends upon the etiology, and we have learnt etiology in a very simple way, BCVA. You all know this is a short form of best corrected visual acuity, but we are using it as causes of conjunctivitis to make life simple, my style. So what are the causes? Bacterial. Bacterial may generally we get a purulent or mucopurulent, but purulent discharge we will learn. Chlamydial, we are going to get a mucopurulent discharge, right? And viral and allergic we get watery discharge, right? So what is conjunctivitis? How the patient will present? Now coming to pathologically, we all know that there are 2 types of reactions when there is a conjunctivitis, and what is that? One is called follicular reaction, which is more typical of a viral infection, and one is your papillary reaction. When there are raised papilla, we all know these are nothing but your hyperplasia of the epithelial line, right? Okay, so once we know this, then what is the treatment? So this is the basic foundation we are discussing quickly. Again, we will see what is the etiology. If the etiology is bacterial, it is antibiotics. Again, it is chlamydial, antibiotics. If it is viral, again antibiotics to prevent secondary infection. And for allergic, we will give anti-allergic and mild steroids. That was quick? Okay. So once we know this much of the basics, we can take one by one what are the questions asked and what are the specific conjunctivitis we have to learn. I'll start with a recent question regarding follicular conjunctivitis, and this is a follicular conjunctivitis, so typical of viral conjunctivitis, okay? And the question they had asked you here was COVID-19. The most common eye presentation, please remember 2 main presentations. One is follicular conjunctivitis and second, the dangerous one is central retinal artery occlusion. Okay? So this is your follicles which are seen. This is your follicular conjunctivitis typical of viral infection which includes COVID, right? So this was your exam question. Okay, so we come to the next type of conjunctivitis now. The next type, what do you see here? This is what is membranous. What will we learn? All the features that you have learned about conjunctivitis. Along with that, when there is a membrane formation, this is membranous conjunctivitis. They have asked you this, what is the sign of a true membrane? What we are going to learn for the eye is that this will bleed on peeling. Please, this is debatable, but we have to answer bleed on peeling. We have checked it. Okay, so this is a sign of a true membrane in membranous conjunctivitis. Next question they've asked you, what is the cause? We all know Corynebacterium diphtheria. How do we treat it? We give antidiphtheric serum, correct? Okay, we come to the next one. This is your pseudomembranous conjunctivitis. How do we know? I cannot comment on the clinical picture only. So, when we try to peel it, we will see. So, all the features, redness, discharge, pain, photophobia, blepharospasm can be there. Along with that, when you get a pseudomembranous membrane formation which will not bleed on peeling. If it does not bleed on peeling, we know we are talking about pseudomembranous conjunctivitis. Correct? What are the causes of pseudomembranous? We will remember it can be mild diphtheria. Please don't forget that. We have an impression, okay, diphtheria only causes membranous. No, mild diphtheria. And there can be streptococcus hemolyticus. And we have severe adenoviral infections. These are the most important ones which you should not miss, right, apart from the others which we have discussed. So this has been asked. So this is your pseudomembranous. Even chronic irritants can cause pseudomembrane formation. We'll remember that. Other viruses, you can remember herpes simplex. Other bacteria, you may remember gonococcus. These are the causes of your pseudomembranous conjunctivitis. We next talk about is this one. What is this? We see subconjunctival hemorrhages. Redness, this is your hemorrhagic conjunctivitis. Hemorrhagic conjunctivitis again is all the feature of conjunctivitis with subconjunctival hemorrhages, hemorrhagic conjunctivitis. Simple. Then what are the causes, I'm sorry. So what are the causes here? We will learn it can be bacterial or viral. For bacterial cause, we will learn two. One is pneumococcus and second is Haemophilus. And when you talk about the viral, we will learn viral can be very quickly enterovirus 70, right? Then we have learned adenovirus, then Coxsackie 24 and Ecovirus 34. If all are given, we mark entero 70. There was a large epidemic of entero 70, they had asked you. Okay. So this was about your hemorrhagic, right? And we will not forget the most common cause of subconjunctival hemorrhages can be trauma. Apart from this, these hemorrhagic conjunctivitis, it could be hypertension, okay? Bleeding diastasis. What else? Pertussis, whooping cough. These can be, what are these? Causes of subconjunctival hemorrhages, right? Okay, next one. What else they have asked you about this picture? Where what you see, sago grain like follicles. What are we talking about is trachoma, right? So when you talk about trachoma, first question is it is caused by Chlamydia trachomatis strain A, B, B and C. It's a disease of children. Strain is A, B, B and C. What does G2K cause? We will learn adult inclusion conjunctivitis, which is also called swimming pool conjunctivitis. Swimming pool conjunctivitis is also caused by adenovirus, right? Okay. What else they will ask you? What type of reaction it has pathologically? So when you talk about trachoma, it has both follicular and papillary reaction. That is important point. And papillary reaction. Another thing, intracellular inclusion bodies are HP bodies, which are called Halbus, Teditor, Provazac bodies. These are intracellular inclusion bodies, right? These are the 2 points for pathology that we are going to keep in mind. Of course, how it will present, the child is having a lot of itching and watering. So it has an inflammatory stage and then there is a secretizing stage. So you get follicles here, and what else you get? Follicles are on the upper palpebral conjunctiva and follicles are also on the upper limbus. These are called Herbert follicles, which are on the upper limbus. And when there is scarring, we all remember what happens when there is scarring. There is a linear scar. This is another exam question. This is called Art's line. And a scarring at this here will lead to, we will say, Herbert pits. All these are cues, correct? Right. Then they will ask you about what is the only complication of trachoma. This is another question. Complication of trachoma is only one, and that is corneal ulcer. We will learn corneal ulcer. Then we talk about what is the WHO classification of trachoma. We all should remember our Fischl classification. They ask you this. We all know follicles, how many? More than equal to 5 follicles. Where? This is asked. Where? Upper palpebral conjunctiva. These are the 2 terms which are asked. I stands for inflammatory stage, where inflammatory stage is when there is itching and watering. S is scarring, that is Art's line, Herbert's pits. We all know this. T is trichiasis, which is misdirection of eyelash. Even if a single eyelash is misdirected, it is stage 4. Okay, this is stage 1, 2, 3, 4. And what is O? Stage 5 is corneal opacity. Due to rubbing of these lashes, rubbing on the cornea can cause opacity. This is corneal opacity. Done? Right. Then what else they will ask you is about safe strategy. We will not forget, this is a WHO program to control trachoma. Right? To control trachoma, S stands for surgery. They have asked you which surgery, you will answer trichiasis surgery. If this is not given, entropion is also fine because almost it is the same thing. Though trichiasis specifically you can remove by diathermy and cryo, but entropion surgeries are different. But if trichiasis is not given as an option, you can answer this. Then we talk about antibiotics. Antibiotics we all know, either it is oral azithromycin or topical tetracycline. Right? So topical tetracycline, which is the choice? Of course, the one where I have to no compliance issue is this. So this becomes the drug of choices. It's easy to eat 2 tablets than to keep putting ointment in the eye. How much percentage of ointment is another question here? Win 1%. Which is another ointment we have learned as 1%, if you remember, is atropine. Okay. So that is the strongest cycloplegic given in children. Remember na? Yeah. Then we talk about is facial hygiene, environmental cleaning. Another question is what is the indication? When will you start safe in any area? We will say when the prevalence of trachoma follicles is in 1 to 9 years of age is more than 10%. Then they have asked you what is the drug of choice for treatment of choice of trachoma. Again our answer will be azithromycin. Correct? Okay, so next what we are looking at, this is not a follicle, these are all flat topped areas, these are papillary hyperplasia, and when it is so severe, this is what is called cobblestone appearance. So diagnosis is vernal keratoconjunctivitis, which is also called spring catarrh, where spring is considered as a misnomer. It happens in spring and summers, mainly in summer. It's a disease of summers. So what are you looking at is cobblestone appearance, isn't it? Okay, this is one question. So let us learn about VKC. This is a mainly allergy towards exogenous allergy, that is dust and pollen, seen in male children. Okay, it's a type 1 hypersensitivity reaction. We have to remember exam question. And another exam question is no follicular reaction. We will know this, no follicular reaction. Okay? Okay, so how does it present? Papillary hyperplasia only, either at the superior and the upper palpebral as you are seeing in this one, or at the upper limbus. When it is at the upper limbus, we have central dots here, and this is what is called, have a look, these are Horner-Tranta spots. So they have asked you what are these? Exam question, these are eosinophils. Horner-Tranta spots are eosinophils. Okay. So then what is the next question they have asked you? Is, of course, the treatment would be all anti-allergics or mast cell stabilizers, right? Like olopatadine, epinastine and sodium chromoglycate. So this is what we will give. So these are the questions asked from vernal keratoconjunctivitis. Okay. So once we know this, and when the patient is rubbing too much, the child rubs too much, do you know the folds that happen at the lower eyelid, Denny Morgan folds, right? And it can also be associated with keratoconus. That's another important point we will remember. So too much rubbing can even lead to keratoconus in a small child. These are the points on vernal keratoconjunctivitis. We come to the next one. What are you seeing? This is a corneal involvement here is what is called Cupid's bow. Can you see this? This is what is opacity on the cornea. This is Cupid's bow. The other name is pseudogerontoxin. Why do we call it pseudo? Because gerontoxin is another name of Arcus senilis. It resembles that, therefore we call it pseudogerontoxin. So it's a keratoconjunctivitis. So there will be corneal involvement in form of Cupid's bow. What else we can get in corneal involvement? If you remember, we have learned shield ulcer, right? This is again vernal keratoconjunctivitis we are talking about. And this is what is shield ulcer. So many times we have learned this, right? Micro erosions and deposition of mucus over it makes it a shield ulcer. This is again case of vernal keratoconjunctivitis. This is again vernal keratoconjunctivitis with a pseudomembrane on the papilla. When there is a pseudomembrane on papilla, this is what is called, what is this? This is called Maxwell-Lyon sign. This is what is Maxwell-Lyon sign. So I think we have to learn Maxwell-Lyon this one, okay? Some variations in different books about Maxwell-Lyon, but we will follow this from now, right? Then we talk about next condition. What are you looking out here? I see a small flectin here, right? We are talking about another allergic conjunctivitis. This time we will learn about flectenular keratoconjunctivitis. It's again a corneal involvement. This is actually allergy towards endogenous antigen. Which endogenous antigen? We will answer. Very important question. First reply should be Staph aureus and second is your tuberculosis. Which was preferred now to answer? Earlier we used to answer TB, but now we will answer Staph aureus as the first job. Okay. Once we know this, of course the patient has a lot of itching and watering. Any allergy presents like this only, right? And what you see here is a flectin, which is nothing but a nodule as you are looking in this way. You already are seeing this and this is the flectin. What happens? When there is a corneal involvement, this flectin may lead to an ulcer formation. This is exam question, fascicular ulcer. So make another cue. Fascicular ulcer may later extend as ring ulcer. Done? And then another exam question, it's a type 4 hypersensitivity reaction. Okay, and the treatment would therefore will be steroids. That was flectenular. We come to the next slide here. What is this? Okay, what I see here is this dried up area. We are looking at Bitot spot, right? So we will be talking about xerophthalmia or vitamin A deficiency. Xerophthalmia, which is also called vitamin A deficiency. So, we will learn the grading, that what is the WHO grading of xerophthalmia. It starts with xn, x1 AB, x2, then x3 is again divided into AB, then comes your xs and xf, right. You all know this? Okay. So, N is nyctalopia, that is night blindness. If they ask you which is the exam question is earliest feature is always nyctalopia, earliest feature nyctalopia. Then second question apart from earliest feature is Bitot spots. 1A you all know is conjunctival drying, that is called xerosis, drying is xerosis. B stands for Bitot spot. Bitot spot is more common on which side? We answer more common temporally. Then 2 is your corneal drying, that is corneal xerosis. Then there is melting of cornea, 3A, this is what is melting of cornea. And when you say 3A, this is keratomalacia involving less than 1/3 of cornea. So, it is keratomalacia in less than 1/3, and 3B is keratomalacia more than 1/3 of cornea. Then comes your excess, which is corneal scarring, and corneal fundus is white spotted fundus is your xerophthalmic fundus is the white spotted fundus. Okay? Next question, which are primary and secondary signs in vitamin A deficiency? All the signs which belong only to the vitamin A deficiency are primary, rest are secondary. So, secondary signs we will learn very easy, XN, XF, XS. Okay, these are secondary signs of xerophthalmia. Another question will be on treatment. We all know how do you treat if the patient is more than 1 year. Injectable vitamin A 1 lakh international unit is given on 0, 1 and 14th day. On the treatment part I am saying it is the treatment. And if the patient is less than 1 year, we will just half the dose, right. When you have to give oral, in each case you double the dose. 0, 1 and 14, 3 injection, 1 today, 1 tomorrow, 1 after 14 days. Do not forget this, it is important, right. So, these are the questions on vitamin A deficiency. Okay, what are you looking out here? This is what is a fundus picture. One of the causes of nyctalopia was asked in your exam, and this is what is Oguchi's disease. What is Oguchi's disease? It is nyctalopia with a pale fundus. Just remember congenital stationary night blindness. We will learn like this. Oguchi's disease is, let us learn like this. It is congenital stationary night blindness with pale fundus. Congenital stationary night blindness with pale fundus. With pale fundus. This is what is called Oguchi's. So, why I am discussing this? There is an important question here about Meso's phenomenon. Meso's Nakamura phenomenon is nothing. You ask this patient of Oguchi's to sit in dark for 1 hour. 1 घंटे के बाद after 1 hour, no night blindness, fundus is normal. Everything is reversed. This is what is called Meso's phenomenon. I am not writing everything, but I think we are revising well. And why it happens? This you can write. This is happening due to, though the number of rods in these patients are less, but it is happening due to overstimulation of rods. Okay.